Hello, everybody in the room. Hello, everybody online. My name is Olivier Pollard. I am the coordinator of the joint action on vaccination, and I am very glad. It's a real pleasure to welcome you today. I will do later a small introduction to the EU-JAV and to this very special conference, which is a closing conference of the EU-JAV. But first, we will have some introductions. And first, an introduction by Professor Jérôme Salomon, who is the head of the Direction Générale de la Santé in France. Thank you, Professor Salomon.
Good morning, bonjour. Monsieur le Président Directeur Général de l'INSERM, cher Gilles Bloch, dear President of INSERM, cher Olivier, dear Coordinator, dear colleagues from the DG Santé, dear EU-JAV partners and dear participants. It's my privilege to open this closing conference of the EU-JAV. This is an important meeting as the joint action comes to a close and we have to anticipate the continuity of our collective endeavors on vaccination. The purpose of today's meeting will be to review the achievements of the EU-JAV and raise awareness among EU citizens on the diversities of challenges regarding vaccine-preventable diseases and the innovative solutions that can be proposed. This day will be also instrumental as an inch towards a post-JAV period where ensuring the sustainability of EU-JAV outputs will be key. I'm sure today's discussions between EU-JAV partners, European partners, and stakeholders will be constructive in ensuring that the work of the JAV can be safeguarded, implemented, and contribute significantly to improving vaccine coverages and improving our preparedness for the challenges ahead. Member state mobilization is key if we want to build further a public health union and achieve impact. Vaccination is one of the most cost-effective public health interventions, which saves, according to the World Health Organization, WHO, between 2 and 3 million lives every year, excluding COVID-19 related deaths. And yet, a number of challenges remain to secure the sustained benefits of vaccination and effectiveness of vaccination programs, both at the national level and at the European level. Equity is one of the challenges we face in delivering vaccine across regions of the world. Vaccine hesitancy and fake news are other pressing issues that need continuous mobilization and renewed public health endeavors. The health crisis has brought major progress on vaccination, though. We have been able to develop in record time COVID-19 vaccines and activate at EU-level mechanisms to support capacity building for sequencing, testing, treatments, and of course, vaccination. The pandemic has made cooperation on centralized procurement of COVID-19 vaccine a reality and has strengthened EU-level information sharing. The European Union and its member states have committed to achieve a global vaccination target of 70% in 2022, agreed at the G20 summit. Europe has developed a digital pass and set the standards, and we have fought together against vaccine hesitancy. In these troubled times, many of the joint action objectives have taken shape. This demonstrates the relevance of the focus of the EU-JAV and its achievements with the gaps highlighted in this unprecedented challenge. The COVID crisis has highlighted the strategic importance of actions foreseen by the EU-JAV 2 years before the COVID-19 virus emergence. Gaps related to many topics identified in the work plan to be improved, such as surveillance, interoperability of systems, vaccine supply, and preparedness. Identification of research priorities and vaccine confidence were all put at the forefront during the pandemic. This joint action started in 2018 as part of Council recommendations on strengthened cooperation against vaccine-preventable diseases. At that time, the recommendation focused on 3 main pillars: tackling vaccine hesitancy and improving vaccination coverage, sustainable vaccination policies in the EU, and EU coordination and contribution to global health. It insisted on targeted outreach towards vulnerable groups, calls to strengthen vaccination training in medical curricula, and exploit the synergies with e-health and digital technologies to establish electronic vaccination records for all EU citizens. These recommendations have been met during the EU-JAV with innovative tools, platforms, and recommendations. I must say that as General Director for Health, I'm very proud to have led a part of the EU-JAV's work and to have witnessed the progress of the project. Sustaining those progress is in front of us. The sustainability report that will be discussed later today offers perspectives for the integration of the EU-JAV outputs within member states' policies for their support at EU level by relevant bodies and roadmaps for the objectives at short, medium, and long terms. It also draws on major reforms of the European Union in response to the COVID pandemic towards a European pandemic preparedness, which create spaces for EU-JAV outputs to contribute to strengthening a European health union. In particular, the evolution of the ECDC, the EMA, and the creation of ERA have met the objectives of EU-JAV outputs in more than one way. The current report identifies these meeting points and the opportunities they offer, not only to the sustainability of EU-JAV, but also to their participation in the implementation of those reforms, always following a will to avoid duplications. These EU objectives regarding vaccine-preventable diseases are still topical, and your presence today is the best proof of our shared commitment for a sustained and coordinated approach to the immunization challenges for the sake of people's health. Thank you very much for your contribution, and I wish you a very fruitful meeting. Thank you.
Thank you very much, Jerome, for this very relevant introduction to our consortium. And now I will leave the floor to Mr. Gilles Bloch, who is the head of the INSERM France.
Monsieur le Directeur Général de la Santé, cher Jérôme, cher Olivier, dear coordinator, dear participants, dear colleagues, I'm very happy to be here with you for the final meeting of this joint action after 3.5 years of hard work. To begin with, I would like to thank the French Ministry of Solidarities and Health for their assistance with the organization of this event. I would also like to acknowledge Professor Jérôme Salomon, the French General Director for Health, for your nice introduction and your support. Professor Olivier Epaulard, the coordination of this action, has achieved a tremendous work over the last years, despite the difficulties related to the COVID-19 crisis. Thank you, Olivier, for all you have accomplished. Finally, I would like to thank Professor Geneviève Chen, who designed and developed this joint action from the beginning and was its first coordinator. First, allow me to say a few words about my institute, INSERM, which was founded almost 60 years ago and is the only French national institution fully dedicated to biomedical research and human health. INSERM operates under the joint authority of the French Ministry of Health and the French Ministry of Research. It is involved in the entire range of research activities, from the laboratory to the patient's bedside. INSERM is a home institution of more than 15,000 researchers, physicians, engineers, technicians, and administrative staff, all with one shared objective: improve human health by advancing knowledge about living organisms and diseases, developing innovative diagnostic and treatment modalities, and conducting research on public health. Today, INSERM is Europe's leading academic research institution in the biomedical field, with over 13,000 scientific publications produced each year by about 300 laboratories. Relying on this ability of INSERM to carry out translational research from the laboratory to the patient's bed and even to the population, my institute accepted to coordinate this joint action on vaccination funded by DG Sanko at European level. For a research performing organization, it is not very common to assume this kind of role. However, in my mind, this role is coherent with our clear vision of the research continuum, from benchtop to bedside and further at the population level, so that scientific advances transform into progresses in human health. I strongly think that one of the reasons of the success of this joint action devoted to help European citizens is that it was driven by a research organization directly collaborating with end users. As this joint action is a success, as you will hear today, the Commission and the Member States should keep on collaborating in the same way, avoiding work in silos. With the new European multi-annual financial framework for the period 2021 to 2027, Europe will invest more money on health through the EU-4Health program and its great budget. And Europe will as well put more money on research through the Horizon Europe program, whose budget has also increased. In order to transform this new funding into success, Member States and the Commission need to work in close complementarity. I know that the different directorates of the Commission try to coordinate their actions, but we also, as research performing organizations, as hospitals, as health institutes, as health authorities, as industrials, or as patient organizations, we need to collaborate and to work together, leaving aside focalization on individual domains. INSERM, who stood out as the main research organization in the societal challenge health of Horizon 2020, INSERM will aim to be a major actor also in the different programs financed by DG Sanko. Among many attractive research areas in the field of health, one has gained even more attention over the last 2 years: vaccines. I like to recall that in December 2019, I was in Brussels at the European Parliament to chair an event about, I quote, new vaccine strategies for respiratory disease and non-communicable diseases. This meeting was organized by INSERM and other French research organizations belonging to Avisan, the French Alliance for Biology and Health Research. We can say today that we had pointed out the right issue. After 2 years of COVID crisis, I strongly believe that we need more than ever to finance research on the first of these two topics, because infectious diseases remain a great threat for humanity. The current pandemic also shows us that we must keep on working on other major issues already identified at the inception of EU-JAV, on vaccine hesitancy, on more efficient funding of vaccine research, on better prevention of vaccine shortages, etc., etc. I know this action has delivered significant results and insightful recommendations on those major issues. These results and recommendations will be discussed today, and I would like to thank all the speakers. Nevertheless, I also think we need to prepare the next steps. Do we need another EU-JAV to go further? How will the new European Health Emergency Preparedness and Response Authorities, the so-called ERA, take these recommendations and results into account? How will the European states, how will the rich network of stakeholders assimilate these results and translate them into national policies and inject them into their own strategic plans. We also need answers to these questions. The joint action brought some answers in a limited time, but new issues have also emerged. I would like to congratulate you about your great achievements, but much remains to be done. I sincerely hope you keep on working together. You can be sure that INSERM will always be an active partner at your side. With the terrible events we are living now in Europe, we need more than ever to strengthen shared strategies, shared research objectives, shared public health visions between member states and with our neighbors. I would like to wish you a great meeting, and I'm now glad to leave the floor to Professor Olivier Pollard. Thank you for your attention.
Dear Professor, oh yes, I can remove my mask. Yes, I'm far away from everyone there. So, dear Professor Jérôme Salomon, dear Mr. Bloch, dear everyone there in the room and dear everyone there online, it's a great pleasure for me to at last introduce you during a physical meeting and not only an online meeting, the EU-JAV, and to present what has been done. Today, most of the floor will be given to the scientists and the experts that have worked tirelessly and endlessly on their different areas regarding vaccination in the EU-JAV. And I just want to make a small introduction. Where does it come from and what was its purpose? We all know the context. Vaccination is a wonderful tool in public health and for the health of population. It can stop pandemics. It has done this in the past, and it is doing this again nowadays. It can prevent infectious disease, and it can prevent cancer associated to virus, for example, liver carcinoma or cervix carcinoma. It is a tool for everyone, from the newborn to the very elderly. For some diseases, there is still no vaccine. I think, of course, of HIV after decades of research. And for other, for example, COVID-19, the past 2 years have been a brilliant illustration of what a vaccine or a handful of vaccine can do at a global level and saving life every day. Yet, when we try to make more and more people vaccinated, when we try to improve the vaccine uptake globally, we are facing some issues. And the vaccine hesitancy, I don't mean only vaccine refusal, but more broadly, some hesitancy is growing globally, including in Europe. We are facing some vaccine shortages. And this impacts the opportunity for people to get vaccinated, but it also impacts the confidence of the public in the health system. We are all producing a lot of data regarding the vaccine uptake, regarding the vaccine coverage in our different countries, but yet those data are not always easy to gather and to analyze at a continental level. We all have difference between our vaccine schedules from one country to another, and this may also impact maybe the confidence of people in the vaccine. And we do not function the same ways regarding the identification of vaccine research priority, of our research funding, and this also can be improved. When Europe faces a problem, one of the ways to address it is to make a joint action. And in the past, the European Union has launched a lot of joint action. For example, one on the health regulation and preparedness in the EU, one on tobacco control, one on the frailty associated with age in the elderly, one on chronic diseases, one on antimicrobial resistance and healthcare associated infection, one on rare cancer, one on nutrition and physical activity. And there is it has been launched for 3 years and a half ago, a joint action on vaccination. And this joint action has a leading purpose. We try to build concrete tools to improve vaccination coverage in Europe and strengthen national immunization program. It has been a very ambitious project, an ambitious consortium with 20 partners, 3 years and 8 months, a budget of nearly 6 million euros. And 5 major topics had been identified when designing it. The vaccine, not only confidence, but also complacency and convenience, all the hurdles that someone may meet when thinking about getting vaccinated. All our national digital immunization information systems, the prevention of shortages, the identification of the research priorities regarding vaccination, the communication, in particular toward youth, and the training, in particular of the healthcare professional. And seeing this map of all the countries involved in the EU-JAV, I can only think about what is happening in the East with the aggression from the Putin administration toward Ukraine. And I can only think of all the scientists, the experts, the physician, the healthcare professional, the stakeholders in Russia and mainly in Ukraine who are facing this event. As one can say, the war is never the solution, and we all need to seek a way to work globally in peace for the sake of the population. In other words, the main objectives and globally the framework of the EU-JAV was along those items. We want to increase public confidence. We want to increase healthcare professional skills. We want to improve the identification of research priorities. We want to improve vaccine research funding. We want to have a better interoperability of national digital systems of surveillance, for example. And we want to do all this in a spirit of collaboration at a supranational level, at a European level. We want to do this in a spirit of synergy between experts, policymakers, NGO, and of course, every citizen. And we wanted to do something sustainable. We wanted something that will last after this joint action. And so these are the different areas that have been covered by the EU-JAV. If my instrument works. This is the EU-JAV of the structure of the EU-JAV. Some teams were dedicated to coordination, dissemination, evaluation, research for sustainability, and others were focused on more precise vaccine-related issues. One team was dedicated on immunization information systems to explore which systems were in place in the different countries in Europe, to use them to build an online platform to visualize the data regarding vaccine coverage, to explore the reminder systems in Europe to be sure that no one is missing an injection and jab. And another part of this team was also dedicated to identify how to launch cross-border vaccination. If the vaccine coverage, for example, identify a gap at a border, to what extent is it possible to launch a cross-border vaccination campaign in the 2 or the 3 concerned countries? One of the team was focused on supply and preparedness to review what has occurred in the past regarding vaccine shortage, to identify the mechanism to forecast the vaccine need and how to improve the anticipation of those needs and how to improve the stocks that we are doing. And to determine whether it was possible to have at a European level a gathering of all this data of anticipated needs, of stockpiling, and maybe to have an exchange possible between countries. And at the end, to obtain what was before COVID, something which appear very exotic, but not anymore, to have a centralized procurement of vaccine at a supranational level. Another team was focused on research prioritization, and they have validated a method to identify in a consensual way the research priorities to be funded in the near future. And this is something that can be done annually to identify annually where we have to put efficiently the funds. And these teams have also worked on how to have some joint action regarding the funding of research, the collaboration in the funding of research. Another team has worked on vaccine hesitancy. First, to collect together all the actions that have been conducted in Europe regarding the vaccine hesitancy and how to address it and how to improve vaccine uptake in the population, to identify what works and what does not work, and to help preparing future efficient action in this field. And also part of this team has elaborated some tools to monitor the public confidence in vaccine by exploring the trends regarding vaccine confidence in the social media, including Twitter. Another mixed team was more focused on communication, and they have elaborated tools, so-called barometer, to measure, to evaluate the need in training of healthcare professionals, and they have elaborated a curriculum to address such need in training. They have launched 2 actions of communications toward youth. Another part of this team was dedicated to the sustainability of all the tools and the recommendation that the EU-JAV would produce. As an overview maybe of the results, we can see all these deliverables, all these tasks that have been achieved, and most of them are available online. And at the end, all of them will be available online, including those that will be delivered in the coming weeks. 3 platforms have been created. They will be described to you today. We have held general assemblies and info day. We have identified a lot of stakeholders. We have presented the project in different external meetings. We have created a vaccine network, gathering all those who have an interest in vaccination in Europe. We have launched 2 school competitions. We have launched a website where we received more than 3 million visits at this day, 1 Facebook page, 1 Twitter account, and some newsletter, and 1 again in preparation, and 1 more in preparation. Of course, it is not possible not to have a word on the COVID-19. I am speaking to you without mask, but I can see everyone there in the room with his mask or her mask. And when the EU-JAV was designed in 2017 or 18, there was no pandemic yet. And we were not focused on such pandemic. Then COVID-19 has occurred, and it has put a very important weight on everybody's life, and including the government, including the healthcare systems. And most of the people deeply involved in the JAV have to be deeply involved in the national response to their countries. It is not a surprise that experts in vaccination, were the most involved in the national response in the past 2 years. And due to this, some work have been delayed. They have been performed, but with some delay. And we have to add an extension of 6 months to the initial period of the EU-JAV. But on the other hand, as was saying Professor Salomon, we have the perception that the feeling that COVID-19 has illustrated with an extraordinary impact how relevant were all the fields of the EU-JAV, the joint procurement, the stockpiling, the address of vaccine hesitancy, the training of healthcare professionals, the identification of research priorities, the interest of cross-border vaccination between 2 or 3 countries. All of this have been put forward due to, I can't say thanks to, but due to the COVID-19 pandemic. And even if COVID-19 was not in the grant agreement of the EU-JAV in 2018, now it appears everywhere in the deliverables and in the tools and in the recommendations that are being produced. Before leaving the floor to the different teams that have worked on those different topics, I want to thank all the EU-JAV partners in the 20 countries, all those people that in the recent years have dedicated some part and sometimes very important times of their lives to the project. And this has led to a success of the joint action. So thank you very much to all of you. And in addition, I would like to thank all the stakeholders that have participated with us in some tools and some deliverables. All the member states, as we're saying, the 2 speakers before me, they will have a key role in the coming months and years regarding the EU-JAV legacy. Everyone at DG Santé and ADEA, all the people that participated in what has been produced and studied, surveyed, the workshop, the meeting, and the assembly, and the French Ministry of Solidarity and Health, who is welcoming us today for this meeting and who have been a support during these years. So thank you to all of you, and let's begin the presentation of our results.
So in this work package, we used measles as an example. For measles infections, there has been effective vaccines available for several years, and all European countries recommend that children are vaccinated against measles. But despite these recommendations and the effective vaccines, we still have outbreaks from time to time in European countries. So following the recommendation to vaccinate, the countries will monitor the proportion of children that is being vaccinated in each country, in each birth cohort, which is what we call vaccine coverage. The method to estimate vaccine coverage, they can vary between countries and they're often not real time. And if a country has a very high national coverage, for instance, the measles vaccines, this can hide smaller subnational areas where you have a low coverage. And subnational and areas or cross-border areas with low coverage might be the reason why we see these outbreaks from time to time. So the objective for us was to sort of find a way to estimate comparable vaccine coverage across borders. To do that, we developed a statistical tool that could estimate the vaccine coverage in a standardized way, and this is what we call the R package. To do this, the country should download this R package, which is free of charge, and then at the local computers, they should extract data from the immunization information systems and run it through the package. And preferably they should do it at the same time in the different countries, so you can compare real-time coverage. This means that countries will have to extract an population file for the population under investigation, and they will have to extract an electronic file with the vaccine doses that is administered in the country. And if you want to act on this, it is preferable that you have real-time data. So how do we want to identify these immunity gaps? You have the local computers, and this is where you have downloaded your R package. You have extracted your data, a population and a vaccination file, and you import them into your computer and run them locally so that all your data stays local. What we would like you to do was to transfer the estimates of coverage. So like 50% of birth cohort 2019 is vaccinated against measles. This is the number. You can't hear me? Oh, sorry. Better? Okay, so you transfer these estimates to the platform, and on the platform we use the estimates to create maps at a European level, as you can see up there, so we can compare coverage between the different countries and regions, and we also create maps and graphs that is more detailed on the national level. Okay, when you want to do this, you have to be aware of one thing, and this is what Olivier mentioned before, that we have different schedules within the different countries when we recommend that the children should be vaccinated. This table is from the ECDC homepage, and it was downloaded in 2020. And the red box up here shows the time for the first dose in the different countries. So it's given mainly between 12 and 15 months of age, but up until 18 months. And the second dose is given between 16 and 18 months, which is the purple box, 16 to 18 months until 12 years of age. And of course, these differences will create immunity gaps, but you just have to be aware of that. Now I'm going to show some output from this R package that you can download. This is Finland, who was part of this study, and they recommend to vaccinate children with the first dose of measles containing vaccine at 12 months of age. So when you extract data in 2020, it's relevant to look at the birth cohort 2019 to see how that birth cohort develops with coverage. So Finland extracted data in March, November, and December, and you can see that in March, Finland is red almost, which is the low coverage, and if you move towards the green and the blue colors, it is the high coverage. So, and this is logical because in March, there's not that many people, not that many children that has turned 1 year or 12 months of age, so they're not vaccinated, and this gives low coverage, of course. But then in November and December, you can see the coverage is much higher because the children is getting vaccinated, but you can see that there are differences between the regions. This is another example. Netherlands also participated. The recommended age of vaccination for measles dose 2 is 9 years of age in the Netherlands. So in 2020, where they also extracted data, it is birth cohort 2011 that is turning 9 years of age. So we extracted data the Netherlands extracted data in September, November, and December. And you can see this was a very peculiar picture because you can see in September, we had very low coverage. There's a lot of red areas, and a lot of difference between the different regions. But it improves when you go to November and December, that the coverage gets much higher, but still there's differences between the regions. So we looked into something else. We looked into the age of vaccination because this tool can also give you the age of vaccination. And here you can see, and I know you can't read the numbers at the figures, but this is again data from September, November, and December. The x-axis is 18 months of vaccination. The y-axis is the coverage. And all the different birth cohorts are, you can see, have different colors. So they are all the lines are all on top of each other, meaning that the children is getting vaccinated at the same age, except the green line, the last green line, which is 2011. This is the birth cohort, they're getting vaccinated later. So we asked the Netherlands what happened during the autumn of 2020. And the reason was that vaccine dose 2 was postponed due to COVID-19. So this gave us this low coverage, but they decided to resume the vaccination during the autumn. And this gave a steep increase in vaccine coverage. So based on this tool, you can also identify if there's any delay in vaccination. So if you want to do real-time cross-border vaccine coverage comparison, you will have to look at the countries together. The 3 countries that provided data do not have a common border, but you can still look at the coverage at the same point in time. So this was extracted in December 2020, and this is Finland, Netherlands, and Denmark. And you can see the highest coverage with the darkest green colors is the highest coverage is in Finland, and then followed by Netherlands and Denmark. And the reason is this difference in recommended age of vaccination, where Finland recommended at 12 months, Netherlands at 14 months, and Denmark at 15 months. And this difference in recommended age will give some immunity gaps. So in conclusion, if you strengthen the interaction of an immunization information system, you can improve the vaccine coverage surveillance in Europe in order to compare coverage between countries, to estimate coverage real time, to identify actual gaps in coverage, and to disentangle delay in vaccination from gaps in coverage. So the harmonized real-time coverage estimation provided to a public platform provides an overview of national and subnational vaccine coverage and can identify the immunity gap either nationally or across borders. And if you do real-time coverage estimation, you have data for action, but you have to be aware of the different recommended age of vaccination.
Hi. We wanted also to show you the demonstration of the pilot platform we developed that is used for comparison of the countries. But unfortunately, we don't have access to the internet to demonstrate it through the presentation. But you can go to the link if you want to your mobile phones or your laptops, and you can keep track of what we're going to show you here. We have some slides, some presentation slides, but it would be much better, of course, if you could see how the platform works real time. So if you go to the platform, and there are several, sorry to describe this, but I don't have the main slide. You have several screens. So one of them is coverage in Europe. Then you also have countries, and you have coverage on age. And this is similar to what Hanne Dorth has been presenting so far. The only difference is that this you can see kind of live, and also you can see all the countries at the same time. So if you go to coverage in Europe, those one, and take birth cohort to 2016, you will see for those 2 countries that we have on platform, their percentage of vaccinated children in this birth cohort by on the status date, which I see you don't actually see because it's too small. It's 7th of December 2020. So this is birth cohort 2016, and their vaccination coverage by the end of 2020. And you can, if you go to the country, so if you go to the Denmark, for example, and you take birth cohorts, so I think you can see on the left, you can see all the birth cohorts from 2005 to 2019. On status date, that's the date of extraction. It's 1st of January 2020, and you can see on the left slide, the left graph, that this birth year birth cohort 2019 has just begun their vaccination. 2018 is in vaccination, and previous years have high vaccination coverage. Pretty much the same thing for MCV dose 1. You can see in the middle graph. So the orange line, the one that is completely below, is 2018. so the one that is in the process of vaccination. And 2019 you can't see yet because it is just started their vaccination. So again, if you go to the web platform, you can see this. If you go to country Denmark, and for example, you choose one of these birth cohorts, say, if you take MCV dose 1 coverage in birth cohort 2018, then you will see the map on the right. And of course, for other birth cohorts that are in the platform, these are cohorts from 2005 to 2019, you will see the percentage of vaccinated children. And there is a slider that you can move below, and the slider will change these graphs. So this is status date, as I said, 1st of January. But if we move forward on 1st of April, you see how these numbers go up. So this is the same graphs. And you see the birth cohort 2018, if you go to the graph on the left side, 2018 really goes up, and 2019 still didn't begin their vaccination. In coverage by age, you can also see the orange line that we have before is getting up, and on the right on the map, you can see by NUTS regions how this is going up to 70%. And if we go to December, then the country is completely blue, which is more than around 90, more than 90%. And 2019 cohort has begun their vaccination. 2018 cohort is finished. So this is an example for MCV dose 1. And again, you can see it on the platform. Another very interesting example is the birth cohort 2011 in Netherlands. This was dose 2, and this is the birth cohort that is vaccinated in 2020, the one that's been delayed. So the same thing you can see on status date. It is September. The percentage is between, well, somewhere even less than 10%, and at some places up to 55. And you can see how it's delayed in coverage by age graph. And of course, if we move to November and again to December, you can see that they are slowly catching up. And I'm really sorry that we don't have much more to present about from the platform, but at this moment. But I would just also like to say there are guidance how to extract your data and the R code also in the platform. And we now have only 2 countries data inside, but it's really easy to use. And we welcome everyone to participate regardless of the end of the EU-JAV project. So basically for the next 3 years, feel free to send the data and use the platform.
Okay, then we also looked a bit on the reminder systems in place in Europe, because reminder systems have been shown reminders have been identified to improve vaccine coverage. So if you remind people about their vaccine, the time for vaccination, you will improve your coverage. So we asked the different countries if they had reminder systems in place, and 17 countries reported that they were reminding their citizens about vaccination. The map you can see is the European map, but the yellow countries are those that we know about, and these are the ones that say they have reminder systems in place. Being gray does not mean that you do not have a reminder systems. It just means that I don't know if what is functioning in that country. However, when we could also see from the questionnaire that the extent of the reminder systems varies a lot from country to country. There are some countries, and this is particularly the smaller countries, they have a national reminder system in place. But the larger the countries get, it is often decentralized systems. It can be run by the regions, the municipalities, the schools, the general practitioners, public health care clinics, baby clinics. There's a lot of different ways this is organized. Some countries remind their recipients that is due to vaccination, others if they did not receive the vaccine on time, and other countries do both. When we asked about reminder systems, we also asked, one thing is to have a reminder system, but how do you contact your citizens or the recipients of the vaccines? And here is a lot of the different answers, but what you can see is that phone and SMS is the most common way to contact people, but letters is also used. Phone and SMS is probably used because it's the easiest way. Everyone has a phone, so you can get in contact with almost everyone by calling them or sending an SMS. And it doesn't require a well-functioning internet connection. And we could also see that phone and SMS was used both in countries that had immunization information system and in countries where this was not in place. But what we could also see from the literature is that it's not so important how you remind. The most important is that the citizens accept your reminders, that you can reach the citizens, and also you can provide the help they need. So the recommendation based on this study was that the COVAX we recommend that the COVAX platform is sustained for future surveillance of vaccine coverage. And we also recommend that European countries provide harmonized vaccine coverage estimates to the platform. There is at the EU-JAV homepage, you can see a report where you can see what we found in this study. But also you can see how to download the report, how to install it, and the user guide. And these are the links, and you can go to if you have a computer with you, you can try it and see how it works. We also recommend that reminder systems are further developed so that we can reach subnational, because if we identify immunity gaps, it's important that you can either reach people living in the community, but even better if you can reach those that actually are not vaccinated. So further development of the reminder systems is also a recommendation. Thank you. Okay, I'll just take this one off. Now there is possibility to ask questions. The idea was that we invited a person from ECDC to participate also because we think this is relevant for ECDC. But we were just informed that they were not able to participate. But you can ask questions to Tamara and me, and I also think that Palle Valentina-Brandt from State and Serum Institute should be online. He is an expert in vaccine preventable diseases and in vaccine coverage. So if anyone wants to ask questions, you are welcome. Palle, do you have any comments if you are online?
Yes, thank you very much for this really interesting presentation. And I think what you have presented is really important way that you have been able to distinguish between just what is the coverage for the individual birth cohorts, but also that you are actually looking into the delay of vaccination and the expected delay of vaccination, because as public health institute working with the performance of the vaccination program, it's really important to be able to identify rapidly things that are happening where you are creating unexpected delays. As you showed with the results from the Netherlands, where it was a planned delay, but you could clearly see it, but you could also have these unplanned delays. You can, for example, have a vaccine scare. Maybe you can have a breakdown of your vaccination system, or you can have a failure of vaccine delivery and stuff. It is really important to identify this early in order to correct it. So in that way, you are moving from a system where you have some delayed information about what is the actual uptake of a burst cohort of a vaccine to a system where you can almost real time identify these unexpected delays because you are comparing to the expected delay of the other burst cohort. So that is really data for action, and I think that is a really huge step forward to have this way of looking into the speed of vaccination as well. We had a problem, for example, in Denmark some years ago where we had a HPV scare among the population, and we could also use this method in order to detect very early some delayed vaccination, and we were able to try to respond to this crisis. So this is my take on this. Really good to have two different ways of looking into the vaccination uptake. Thank you.
Oh. Then I would like to ask the participants here, because now it was Denmark, Finland, and the Netherlands who provided data. And I can tell you that we had contact with the different countries, and we talked about how to install the R program, how to prepare the vaccination file so that you could run the coverage estimation. And as soon as that was up running, I could send an email to Finland and Netherlands saying, could you please extract data tomorrow and provide me with some coverage estimates? And they could. It took very short time. So would any countries be interested in providing data to this platform or a similar platform? Søren?
Il faut prendre un micro, merci.
Maybe.
Thank you. Well, Sweden should have provided, and we made some efforts, and partly, I think, due to the COVID pandemic and the people in charge of the registries and so on did not manage in the end. But with the work that has been done, I think we really should make an effort to try to continue. I think that is the challenge now for the future, because we have this tool. Not just to leave it there and not to use it. So how do we take it to something that is used in the future also? Thanks.
I think maybe it is not necessary that every country, all countries start to providing from the beginning, but it would be nice if countries would sign up for such a thing, because I think it's a really valuable tool. At least we learned a lot when we looked at data over time.
Good morning, I'm Karianne Johansen from Norway, and we really looked into delivering data to your platform, but when we were very uncertain if it was indirect identifiable data, we had to run through our security systems in the surveillance registries. And I think that was a bit confusing for us, what kind of data you ask for and what should be delivered. And we also have our own rules too. For instance, when we calculate measles coverage, we really have very distinct rules in our childhood immunization programs. And we have our official statistics, and we don't want to have two different statistics, one European and what is actually deviating from the Norwegian one. I think that was our issues, and that's why we didn't deliver data to the platform. Thank you.
I think you can use maybe the R program just to check the consistency of the data that you would then provide to the platform. Maybe that would be one of the ways, and it shouldn't be two different data, it's the same data. Also regarding what kind of data, it's aggregated data, of course. I mean, for running the R code, you can also use individual data, but then again, the output is aggregated. So basically what you have is a birth cohort, age in months, and number of children and number of vaccinated children in that group. So this is something that is not identifiable in ways that should be problem to, I don't know, GDPR or something.
Hanna Nonek from Finland. Thanks a lot for excellent presentation. My concern is the sustainability. ECDC is collecting coverage data for all the childhood vaccines and hopefully also the adulthood vaccines in years to come. How are we securing that what you have developed actually is being maintained and used, and issues like what was raised by Norway are solved? Because most issues are solvable. It's usually a question of understanding and dialogue. So how do we make this sustainable?
I can start answering, and maybe Hanne Dorte can fill me in if I said something wrong or missing. So for now, we have secured the sustainability of platform for next 3 years, which is short because then it's still not sustainable. And we wanted to discuss, we were in some discussions with ECDC representatives, maybe to take parts of our platform and integrate it in their systems, because we are aware of the ECDC Atlas of contagious diseases, and we are aware that in the meantime, after we already started the project, they've been also developing their own maps. Now, what we think that could be integrated from our project is one, it's the R code, because it's really simple to use. And of course, then you don't have to upload the data on the platform. It is good because then you can see the cross coverage, cross borders coverage, but you can use it to run locally, which is really good because then you immediately see, you don't have to upload anything. So this is one of the things that we would like for the ECDC to consider. That it is really user-friendly and you don't have to upload it necessarily somewhere, but you are kind of in charge of what you want to see and what you want to get. And the other thing is that we have NUTS levels 3. So our maps currently are more detailing in compared to what ECDC has, its country level. So we were discussing, these discussions are still not over, and we hope that they will recognize the potential and probably take some parts of our platform and the code and then adapt it to suit their own needs, and maybe that is kind of securing the sustainability.
If I could just add that exactly what you're saying, Kajana, about that you have your very clear definition on how you estimate measles coverage. Maybe that's also one of the problems that we face, because you will never get real time, or you will if you estimate in different ways, it's extremely difficult to compare between countries. So you can say, if you want to find these gaps or you want to act on them, then I think you need a comparable way to estimate coverage. But I think maybe I didn't make it clear during my presentation. What I presented was the output from the R package. So Finland and Netherlands, they sent me the output so I could sort of prepare the report. So this was what from their local aggregated data so you get exactly the same output as is on the platform. So you can run it and look at it at your own computer. You can see, is there something strange here? So I think it's a good idea just to try it, to see how it works, and then see if you would be interested in working with it. I don't know if there is any representatives from ECDC or WHO who can comment on it, but
In the meantime, maybe I have a question regarding the reminder systems. After doing this survey in Europe, what would be now your best definition or your recommendations for the best system of reminders? How does it work? How does it contact people? Is it for every age, the parent of the small children and the elderly and the adults and so on? What would be your recommendation for the best system?
I don't think I can say what the best system is, but what some countries responded was that if you want to reach remote, maybe populations that is in poor areas, they will not have an internet connection. They might have a phone. They also said that it is cheaper to receive SMSs. So SMS is or text messages is important compared to a phone call, which is more expensive. So things like that, I think you need to consider in your country. So it's not I don't think there is a best way. I think, and this is what all the literature I've been through said, that it is important to tailor your program so you reach the population that is, but you of course you need to be able to identify the populations, but it is important to be that they accept the messages you send about vaccination, and maybe also if some areas you need to contact them or visit them or something else, then I think this is the important way, that you really tailor your reminder system to reach as many as possible. Sarah?
Hi, thank you so much for a really interesting presentation and discussions. It's just bringing up quite a lot of issues that we have looked at in the cross-border vaccination campaigns that we'll come on to in a minute. But I think that at an international level through the system, it's possible to identify areas of lower vaccination coverage. And I think also through collaboration and sharing of best practice, it's possible to identify key characteristics of reminder systems that are useful and that work, and that can be shared across borders. But I think from the discussion it's also, and from the literature that you refer to, the actual application of the intervention then really has to be designed locally or at the level that the program, the vaccination program is organized, or even more locally in the case of sort of low vaccination groups and populations that need these sort of very tailored interventions. So there's several levels of complexity in this. And I just wanted to sort of emphasize that part, that it's really good that we start talking about this, and there's so much that we can do in terms of collaboration across borders for sharing the best practice and the best knowledge from the literature. But I think that there is still this place for kind of the locally implemented interventions that are at the same level as the vaccine programs are implemented. So it's not a one-size-fits-all approach.
Just maybe for a last remark, I can say that one of the things that surprised me was that very few countries is actually translating their reminders. Maybe it's not necessary. I know in Denmark we are translating to a lot of different languages to reach population that is not born in Denmark but live in Denmark, where it can be difficult to reach to receive letters from the public like saying you have to get vaccinated. How do you understand this? So this was one of the things that surprised me, that few countries reported that they translate their reminders.
And we have a message on the chat from the ECDC from Tarek Derouf saying, thank you for the presentation. Since the onset of the COVID-19 pandemic, ECDC had developed a tool to monitor COVID-19 uptake, the COVID-19 vaccine tracker available online. And they are planning and strongly considering to use this tool to collect and display uptake for other vaccines and vaccine coverage. This also in light of the ECDC new mandate to engage further into coverage monitoring. We are grateful for the work done by the JAV in this regard, and the experience gathered will be necessary. We hope to have further discussion with the specific work package leaders, and Daughter and Tamara, and again, apologies for not being able to be with you and to intervene, I understand. But thank you for the mention. So I expect indeed some discussion to, as we were already saying, to occur between us and the ECDC in the near future.
Great.
Thank you.
Okay, there is maybe a last question also in the chat. It's not easy to resume, and I think it's even more difficult to answer, but how do you see that COVID-19 that has cast a light on such a platform? What are your reflections concerning such a platform regarding vaccine coverage, COVID-19 vaccine coverage?
You could set it up for vaccine, COVID-19 vaccine coverage. Of course, you will have to change the tool behind it, because now it's measles, so it's 2 doses. If you have a COVID-19 vaccine, you'll have 1, 2, 3, 4, 5, 10 doses maybe. So you'll just have to set it up, and it's not so much birth cohort related, it's more population related. So you'll just have to rethink the sort of the algorithm, but you can set it up for any vaccine in principle.
Okay, I guess. So thank you. Thank you, Daughter, and thank you, Tamara. And now I will give the floor to Søren Andersen and Sarah Enschel-Blomqvist, and they will speak on feasibility study on EU-wide and cross-border campaign on vaccination.
So, good morning. We will present the work that is. Oh, sorry. Yes, I'm too tall for this. Hope you can hear me now. We'll present the work that has been performed on feasibility study on cross-border vaccination campaigns. And we're from the Swedish Public Health Agency. I'm Søren Andersen, and with me is Sarah Enschel-Blomqvist. Now we'll see if I can handle this one. Yep. So the original scope of this task was to look into the possibilities to perform coordinated EU-wide measles catch-up vaccination campaigns to tackle common immunity gaps linked to the development of a cross-border IIS, and this was part of work package 5. And it turned out already in the beginning that there were some difficulties with this task and this scope due to a number of reasons, difficulties in identifying common immunity gaps, lack of comparable cross-border data on the reasons behind low coverage, and so on. And also, as has been mentioned before, the heterogeneous nature of vaccination programs. So, and then in addition, of course, the pandemic came with all that followed with that. We could have had and utilized the work that has already been presented now by Hanne, Dorte, and Tamara, but that was also part of the work package. So we were working in parallel. So at this stage, we could utilize some of the results for this work package. So with that as a basis, the scope was widened. to look into possibilities to inform future cross-border vaccination campaigns in general, and with the more specific objectives to review what has already been done along these lines, to consider what can be gained by teaming up, to document the perceived facilitators and barriers, and to identify themes for future cross-border collaboration. And we started with meetings with representatives of WHO Europe, ECDC, to inform and to set the stage for this work. We then collected data through a survey that was performed in collaboration with our collaborators at Work Package 8. They will present their work later on today. But our part of that work will be presented soon here. We then also performed workshops both in conjunction with the Rome meeting and with face-to-face workshops then, and then also digital workshops, a number of digital workshops in the end of last year, with the participation of a number of countries in the JAV and also from other stakeholder organizations. So with that, I will hand over to Sarah to present the results, and that will also lead into a panel discussion on the possibilities and challenges based on the data that we have found. So Sarah, please.
Now I need to move the microphones down a bit. I'm a bit shorter than Sarah. No problem. Okay, can you hear me? Yes, good. Thanks very much for introducing the changes to the scope from what had originally been planned, Sarah, and the methods. And now I'm going to go on to presenting briefly the results before coming into the panel discussion, which is going to be the most interesting part, I think. So the results from the cross-border questions, which were circulated as part of the Work Package 8 on vaccine hesitancy, showed that only 9 of 28 countries in the EU and associated countries that participated in the Work Package 8 survey reported having worked across border on vaccination campaigns. And what we found when we asked questions like, for example, have any interventions to address barriers and drivers to vaccination been done as a collaboration with cross-border partners, or have any studies to barriers and drivers of vaccination, including literature reviews or sharing of data, been done as a collaboration with cross-border partners, was that there was a tendency for more Central European countries to respond in the positive, whereas the northern countries tended to be more responding in the negative. We do think that this is an underestimation because some could even describe the JAV as a cross-border collaboration. And we think it also depended on who in the vaccination programs were responding to the surveys. Jonas maybe will go into that in a little bit more detail, but I think in some countries it was a sort of collaborating group from the vaccine programs that responded to the survey, whereas in other countries maybe it was one individual who responded rather quickly because it was in the middle of the COVID pandemic. But this gives us, in any case, a broad indication of the fact that there's not that much collaboration going on across borders on vaccination campaigns as it stood at the time of the survey. In terms of the more detailed results from the survey, in terms of what these collaborative efforts across borders might look like, the participants reported on research groups, a method for tailoring immunization campaigns to specific low coverage populations or individuals. This is where certain countries participated in the WHO TIP tool, for example, platforms for exchange, such as neighborhood collaboration on vaccine coverage and acceptance in the Nordics, for example.
And the big European-wide annual vaccination campaign that WHO leads, the European Immunization Week. We also asked about what could be the benefits of collaborating cross-border and what type of incentives would encourage more cross-border collaboration. And in terms of the benefits, participants in the survey raised issues such as sharing of experience on studying vaccine hesitancy and best practice between countries, sharing of data, and collaboration in reviewing the scientific literature, which can be incredibly time-consuming. And then incentives would be many people raised this issue about platforms for exchange, making it easy to collaborate across borders. For example, workshops or telephone conferences, but there are also many other types of platforms. We also asked about how knowledge from cross-border collaborations has been implemented in terms of the vaccination programs. And these are some of the examples that participants gave. So improving the communication between healthcare workers and vaccinees, measurements for vaccine acceptance, training of vaccine program administrators, vaccine registries and reminder systems we've talked about today, high-level advocacy for political and financial commitments. You need budget to be able to make actions happen. Vaccine decision tool and conferences and seminars. So this really broad range of actions where data from cross-border collaboration has been used. There are also a lot of difficulties reported in terms of the cross-border collaboration, and the team analyzing the results from Work Package 8 developed this table, which divides up the difficulties into three main themes. So the social cultural differences, like language and culture, historical context, trust in authorities, the institutional differences, like the health system, the objectives of health departments, differences in IT systems, and different vaccines or vaccine targets, and resource differences. For example, that doesn't apply so much now, we can have digital meetings. You don't need to travel anymore to a meeting with your colleague across borders. But the financial burden and lack of data, now we've solved that problem. And so I think when designing cross-border campaigns, it's really important to take account of the local context in order to avoid campaigns becoming more burdensome than beneficial. And then we were asked also by the Commission to include reflections from COVID vaccination. So what kind of platforms have we seen for EU-wide collaboration or cross-border collaboration during the COVID pandemic? And there we've seen, of course, this very successful EU mechanism for purchasing of COVID vaccines, which is a wonderful example. But we've also seen the regular EU technical exchanges through both the EU Health Security Committee and the ECDC NITAG platform, which has really blossomed. And we've also seen this WHO community of practice on behavioral and cultural insights, where we're developing and sharing data, real-time data on vaccine acceptance, and also discussing how to use this data for implementation in terms of risk communication. And then we've seen some neighborhood collaborations as well, supported by the EU. So we heard that in the Baltics, there has been a specific collaboration on vaccine supply where one country had a shortage. And also we heard that in Romania, Hungary, Germany, and Austria, there has been a collaboration supported by the EU on reaching low vaccination groups. And some smaller countries in particular have requested more support. And then also we've heard about the development of a number of very relevant EU-funded projects under the Horizon 2020 and the third EU health programme that can provide really essential learnings for us to take forward as part of this work. So overall, we've identified in our final report 13 themes where we think that value can be gained by cross-border collaboration. And that's based on the analysis of the participant statements from the workshops as well as the results on the survey. And we think that these 13 themes can be used as an operational hook for really anybody who is thinking about designing some kind of cross-border vaccination campaign. I'm going to present very quickly on the 6 of the themes, some of the examples that were given, and then we're going to go into the panel discussion, which can cover any of the 13 themes. So For example, one of the themes is low vaccination populations. How do we target and increase vaccination coverage in some of these low vaccination populations? And how could this be a theme for working across borders? And then we think, well, there are some common issues across borders, like, for example, with migrant workers or diaspora that you find in many of the same diaspora in the various EU countries. Also, maybe there's issues around unknown vaccination status of foreign workers and their families. And there was even a suggestion that the children may be their vaccination checked before they start school. In terms of communication strategies, there are a lot of ideas for how we can share best practice across borders, from sharing patient stories, which is so hard to find and research. For example, the wonderful and very moving story of the HPV cervical cancer patient, Laura Brennan from Ireland, that has been used across borders. How we can, common strategies for reaching social media users, such as mothers on Facebook. Common approaches to explaining the risks of not vaccinating children. We talk a lot about the benefits of vaccination, but could we have some common messages around what are the risks of not vaccinating? Also monitoring the social media in terms of anti-vaccine discourse and disinformation. I think that's covered in Work Package 8, so I won't dwell on that too much. And also how we work with the media to communicate the benefits of vaccination. Neighborhood and twinning issues has come up a lot. So how can we have more platforms for exchange and support in small groups? Sometimes I think people feel in the big EU-wide group, it's quite difficult to have a meaningful discussion or to get your points across. But in a small group of context-similar countries, this can be very helpful. Comparable data on vaccine acceptance. This is a really big one. And I think that we're making some progress in this area through the COVID pandemic, but sharing tools and experience on behavioral and cultural insights, as well as the medical and epidemiological aspects of vaccination is really important for being able to compare data and identify trends across border. And then these coordinated literature reviews that I've mentioned that are so time consuming and resource consuming. How can we collaborate more on doing these reviews of the international scientific literature? And in particular, for example, identify new practices for the real-time social media monitoring of questions and disinformation, because there are so many different groups doing research into this area now. And the training of healthcare workers, where quite a lot of work has already been done across borders. Some of the issues raised were such as that healthcare workers are not sufficiently aware of the need to check vaccination status of adults, that there needs to be much more vaccinology and communication skills in curricula for healthcare workers, that there are groups of healthcare workers and students that are anti-vaccination, and that there is this general concern over unvaccinated healthcare workers, a lot of the issues that we're very familiar with. So here is a visual of all the 13 themes that we've identified that can be valuable for cross-border coordination. They're adult vaccination, working with pharmacists, political advocacy, training of healthcare workers, technology tools, communication strategies, low vaccine populations, training risk communicators, neighborhood twinning initiatives, coordinated literature reviews, one voice key messages, stakeholder engagement, and comparable data on vaccine acceptance. So there's lots we can do. What I want to do is ask 2 questions to the panelists. So one question, and what I would like the panelists to do is to maybe use 1 or 2 of the themes as examples in their responses. The first question is, what is your vision for enhanced cross-border collaboration on some particular theme by 2030? And the second question is, what 1 or 2 concrete steps could you take in your own context to move in the direction of this vision? And we're very happy to have with us, I think, digitally, Alison Mawson from EuroHealthNet and Karam Adel Ali from ECDC, as well as 2 colleagues in the room, Jonas Sivile from the Finnish Public Health Authority. Do you want to come and sit in one of the chairs on the stage? And the head of the Swedish vaccination program, Søren Andersen. So we'll go, is it okay, Olivier, if we go straight into the
Karam is there. Is Alison there?
Yes.
Great. Hi. So if I start with Alison, on a couple of the topics that we've picked out as themes for possible cross-border collaboration, could you tell us for 1 or 2 minutes what would be your vision for enhanced cross-border collaboration by 2030?
Sure. Thank you so much, Sarah and Soren, for this, for the presentation, and to everyone for the opportunity to come and speak. It's really a pleasure to be here as we've been closely following your work over the last few years. So I'd like to say that I'm speaking today not only on behalf of EuroHealthNet and the Immunion project, one of these third health program projects that you mentioned, but also on behalf of a wider group of ongoing Horizon Europe and EU health program projects. So I would say each of us represents a cross-border collaboration in our own right, but we've also started to recently collaborate amongst projects, cross-project collaboration, because we see that this is another area where we can really make a greater impact. So we've been having a series of teleconferences and establishing some working groups to work together on common themes. And I'm really happy to say that the focus areas of our projects and of these working groups very closely mirrors these areas that you have just outlined, these 13 areas for potential collaboration. So you've talked about training of healthcare workers. That's a central theme in a number of the projects. So we're engaging to make sure that as we make requests of healthcare workers, we're not asking them to fill repeated similar surveys. We're really trying to coordinate our efforts so that we don't burn them out, and so that what we create in service of these healthcare workers is as effective as it can be. And we're also coordinating with one another and with the WHO Europe Regional Office on a sort of one voice key message, as you've mentioned, right now, specifically around the European Immunization Week that will come at the end of April that you've already mentioned. So in preparation for today, I asked some of the other project coordinators what are the key benefits that they see of teaming up and working together across borders. And they really stressed the importance of preventing reinventing the wheel. So, for example, when it comes to measuring vaccine hesitancy and also exchanging on the benefits and challenges of various research approaches. They also talked about enabling cross-country perspectives, such as identifying patterns that we see in fake news or in vaccination myths, while acknowledging country-specific issues. They talked about increasing the generalizability of the results of our projects and improving understanding of various models of vaccine provision, greater translation of key insights into multiple languages and contexts, and contributing to keeping this issue of vaccine hesitancy high on European and national public health agendas. So my vision then for 2030 would really be to establish more formal mechanisms to maintain this sort of collaboration across borders and across projects and across initiatives that all share similar aims. And I was really pleased to hear that in the welcoming remarks this morning as well, a kind of focus on what are the next steps and how do we continue to work together. So I'm sure I've gone over my time. I can close there for now, but looking forward to other remarks. Thank you.
Great, thanks so much. I'm going to move straight on to Karam Adel Ali from ECDC. Please tell us what is your vision for enhanced cross-border collaboration by 2030?
Hi, Sarah, and good morning, everybody, and thank you for inviting us to be part of this discussion, which is critical. Of course, we think that the nature of our work is really working across borders. That's why we were established in the first place. And I think that we have been able to break down a lot of barriers before and certainly during COVID-19, where we've seen an increased cooperation on several fronts and several areas where cooperation hadn't taken place before. And I think that was outlined very clearly by Professor Polar in his presentation at the beginning. One theme that I would like to pick on that you've mentioned is the theme of communication, especially when it comes to communication strategies, when it comes to being able to coordinate efforts in terms of communications to the public, communications to different stakeholders on vaccines and immunization. And I think that the COVID-19 pandemic has shown us again the importance of ensuring a consistency when it comes to key communication on vaccines, and especially the situation of rapidly evolving situation concerning the evidence that is coming out around these vaccines. It has been very clear, I think, from the very beginning of the rollout of the vaccination program, that the issue of potential inconsistency in the way we communicate about how programs are rolled out, in the way we communicate around certain specific products, is no doubt one of the drivers of hesitancy and one of the issues that causes acceptance issues when it comes to uptake. We are used to think of vaccination hesitancy and uptake issues mostly from the demand side, but we need to really think carefully also what happens on the supply side, and the fact that if we create consistency in the message that we give as public health authorities, that's of course an issue. And we know that the mechanistic way of communicating, in a unilateral way towards the public just does not work anymore. So I think that one critical area of cross-border collaboration is finding and devising ways in which we can probably work in a better, more timely, anticipating way on the messages that we give around vaccines and vaccination. The evidence behind the vaccines is really the same. The way we implement vaccination programs can be different for various reasons, also for valid reasons. But the way we communicate on the value of these vaccines and how these vaccines should be used should be something where we can find definitely consistency. Another area that you mentioned in the 13 boxes that you've shown us is the one about what can we do in terms of joint efforts when it comes to coordination around systematic literature reviews. And this is a topic that has always been at the heart of the work that we do at ECDC, and that has been at the heart of the collaboration among NITECs that we have established and that has really bloomed. I like this word that you used during the COVID-19 pandemic. Of course, it's a challenge. Everybody's doing literature reviews. Everybody's looking at the evidence in their own way, according to their capacities and resources in their corners. But there is no reason why we would not be able also in that area to find efficiency gains. And I think that that has come out also very clearly from the draft report of the NITEC reflections that you have done within the NITEC's task within Work Package 4, which we've read with great interest. And that's something that we really want to look at. So from that point of view, I would say that our vision is to be able to better map what are the needs in the short, in the medium, and in the longer term of different NITECs working across Europe, and maybe finding a way of identifying efficiency in the way we use resources and avoiding reinventing the wheel, just as Alison mentioned earlier in the areas that she covered. Over from my side.
Thanks very much. I'm going to ask the same question to Jonas Sivile from Finland, also representing Work Package 8 on vaccine hesitancy.
Thanks, Sarah. Can you hear me? Good. Thanks for a great presentation and great comments from the previous panelists. On a very general, in a very general sense, having worked with the joint action and especially with vaccine hesitancy and uptake during the last 3.5 years, I would say that if we want to improve cross-border collaboration in general, we need to have concrete instruments and tools to do that. And I would say that the joint action has been a good example of an instrument that has brought us together and given us opportunities to collaborate. But we need more of these. You already mentioned the WHO group on behavioral and cultural insights, community of practices group, which is another really good example of an instrument that exists, and that's very concrete. And I think it is through these that we sort of make it possible for us to collaborate even more, which is necessary for many reasons. Another good example is of a collaboration instrument is our Nordic vaccine acceptance and hesitancy group, which Sarah also is a member of, and the Nordic countries have already in 2018 we launched a group for people working at the different public health institutes with vaccine hesitancy and uptake issues. It's a mixed group, both with people both with working maybe more explicitly with research and with people working often more with communications and both. But I would say that this is also maybe a good thing in the sense that it brings people from different backgrounds together to work with different issues. But I would say that key is different concrete instruments for us and have those and make those sustainable, definitely.
Great, thank you. And finally, Sarah, do you have any additional comments on your vision by 2030 on any of these themes?
Yeah, thank you. I'd like to briefly comment on two of the themes, of the 13 themes that have been brought up. First, on adult vaccination, that is something that I think we're all dealing with in different ways and with different ambitions, and it really reflects the issue of lifelong or life course vaccinations that we're focusing a lot of children and youth, but in order not to get gaps of protection immunization waning until we get very old. I think it's important to look into how this can be accomplished. And I think this is also become evident by the COVID-19 vaccination work, and which we don't know yet what the future will be, but we're covering most ages, many of us, with these vaccinations, and we will probably for a fairly long time have to continue to boost and so on, and so perhaps that could be used also as a basis for widening up and looking into other diseases, vaccine preventable diseases. In Sweden, in order for a vaccination program to get the status of a program, national program, it has to be decided by the government, and then what follows is that the regional authorities have to provide the vaccines, and the cost is provided by the government. So, and we are now taking a first step this year by introducing pneumococcal vaccinations as for elderly and risk groups, I should say, as a vaccination program, national program. It's already been recommended, and many regions are already provided, but there's been differences in coverage depending on where you are in the country, where you live, and so on. So this is something we've been, Sarah mentioned that also, working together quite intensively on the COVID-19 vaccination campaigns. So it would be very nice, I think, to develop that further to other areas as well, and not drop the COVID-19, of course. Then the other theme I'd like to comment briefly is related to that, and that concerns the technology tools. And again, the COVID-19 vaccines and vaccinations is a beautiful example of how we can and had to collaborate in order to go about this challenge. And it would be very nice to see that being expanded to and further developed into other areas as well. This could include vaccine development, but it has also included the regulatory aspects and other issues. But it could also, technology tools could be anything from IIS to how to administrate vaccines and so on. So there, I think only fantasy can set the limits, and perhaps the work package working on research priorities will come into some aspects of this also. So I'll stop there. Thanks.
Thanks very much. Do we have any more time, Olivier? Great. Okay. I did want to go around the panel once more and just push you a little bit harder for some concrete actions. I think it's very good, the discussions that we've already had, but if you had to take one or two concrete steps in your own context to move forward to the vision that you've described to us, what would they be? Alison, I'll start with you.
Sure, thank you. So yes, I think this is, let's say, an easy one for me because I'm familiar with a lot of projects that are taking concrete actions right now. And I think given that we've already had excellent remarks from other colleagues on some of the specific topics, maybe I can mention, for example, you have working with pharmacists. And I would say it's even broader than that. It's working with healthcare professionals as a whole and associations of healthcare professionals. And I think many of you are probably already familiar with the Coalition for Vaccination, which was established in 2019 following the EU Council recommendations on vaccination. And this is an initiative of healthcare professionals and student associations working in the health field, who are all trying to come together to really coordinate their messaging around vaccines, to exchange on experiences, and to debunk common myths, kind of improve the communication with the public, because we all know that healthcare professionals consistently in survey after survey are found to be the most trusted source of information on vaccines. And so a very concrete step is to make sure that we can strengthen this existing coalition for vaccination by giving them more visibility and also by creating more links with projects like EU-JAV, with institutions like ECDC, and ensuring that there's a space for them to continue to reach their communities, which are millions of healthcare workers across Europe, with their messages, and then also influence messaging happening in high-level fora by feeding up, from the bottom up, the kind of information that they receive from their members. So that's something that's very concrete that we're working on in a project. And then I'd also like to say about training and specifically training of healthcare workers in relation to all of this. This is a huge focus that we're seeing across all of the projects, and there are a lot of really exciting initiatives coming up. So trainings of trainers, specifically around vaccine communication. I know that that's something we're working on within Immunion. It's also something that I believe ECDC is taking forward a number of initiatives on. There are some great activities coming out of a few of these projects on identifying, we talked about vaccine hesitancy. We'll hear more in Work Package 8 about this. But vaccine hesitancy is another huge focus across all of the projects. And there's a very interesting taxonomy of fallacious arguments around vaccines that's been introduced by the project JitsuVax. And they're going to use this kind of taxonomy to then develop a series of counter arguments that could be used against these types of common myths and develop a training around this that's available for healthcare professionals. So I could go on and on. There are lots of interesting things, but yeah, I think the point being, the key message being, we need concrete tools, as Jonas was saying, we really need concrete tools and mechanisms to continue to have conversations like the one we're having today. And I think it's very important that member states who are represented within the EU-JAV are primary drivers for this, but that they don't only keep the member states themselves in mind. I think we need to really develop a big tent and think who else needs to be involved in these conversations, and whether that be coordinators of projects, whether that be representatives from the pharmaceutical industry, whoever it is. We know that we're sharing a common goal of trying to increase vaccine uptake, and collaborating and sharing on our specific actions is one of the best ways to do that. So thanks, Sarah.
Thanks. Karam, your one or two maximum concrete steps to move forward.
Sure. I think the first thing for us is to distinguish between wanting to support and to promote cross-border collaboration and expecting a unison or a harmonized way of doing things. I think it's very important to distinguish these two things. In the European project, this the natural tendency or the natural way of doing things to want to harmonize, to want Europe to have a common approach. This is the case also in health, even if it's less so, of course, due to the limited competences. But I think we have to step back sometimes from these ambitions, from wanting things to be the same. They're not the same for valid reasons when it comes to the implementation of vaccination programs, historical reasons, cultural reasons, the way the healthcare systems are designed, etc. However, we can promote consistency, I think, in the way things are done, in the way we believe modernizing or bringing forward vaccination programs could mean or should mean, where they should go. So it's more about setting the goals, setting the objectives, and setting the standards, but then it's for countries to find the best way according to their context to do that. And more concretely, from our perspective, probably what we see makes sense, because we do work constantly on a cross-border dimension, is to foster in an active and a dynamic way an environment that is conducive to collaboration between the countries, feel safe in sharing their experiences, sharing their practices, documenting these practices, regularly building bridges between the countries. What we see is that this is what builds trust. This is what enables countries to talk to each other, what enables countries to then develop initiatives, which can be initiatives that are completely outside the work that ECDC does, or initiatives within the platforms that ECDC hosts. And I do agree with what Jonas says concerning the fact that we need concrete tools. But I would also challenge a little bit this idea, because there are a lot of tools that are either through, for example, the platforms we have available, or what the Commission has available, or what is funded through different EU funding programs. So perhaps it's also about better leveraging the tools that we have, refining the tools that we have, and finding ways that make sense for the countries, and also, of course, for the actors that are operating these platforms and tools to try to build this convergence. But I think the concrete step for us is really to continue to work very hard to foster a dynamic environment where countries can come together and where we can have a convening power, if you like, to be conducive to creating this collaborative environment where we believe is the first step for real cross-border collaboration.
That's great. Jonas, do you have any additional concrete steps? One or two maximum?
Or
no.
No. You can. Okay,
now,
good.
yes.
Thanks. Thanks, Karam. Just a quick answer to your comment there. What I was maybe meaning, or I'll try to articulate it better. I know we have a lot of concrete tools in the form of platforms and such, but what we need more, I think, is sort of tools that bring the people together, the people who work with these issues together, and have sustainable places for us to work with. And I already mentioned some examples, but well, looking at a couple of concrete steps, I would say we have already some of these collaborative spaces that we use and where we discuss. I think we're already in a stage where we can sort of take the next steps. We have been meeting and discussing things for a long time. I think it's in many of these groups and in many of these sort of collaborations, we are already in a place where we are able to do more concrete things together in the form of research, for example, in the form of different kinds of actions, activities, whatever that may be. It doesn't always have to be a campaign. Another thing which I would like to see is that often when we work with hesitancy and uptake issues, for example, which is quite normal because people who work with these issues come from different research institutes or public health agencies, we do a lot of research about how things are. We try to understand. I would say that we understand quite well already. We have quite a lot of studies. Of course, we need to be updated, and many of these studies need to be more context specific. But what we really need to push forward is the research-based actions based on all the knowledge we have. And when I look at the huge data we gathered in work package 8 that we will tell you about in a while this afternoon, we can see that a lot has been done. But there is a strong emphasis on research, understanding the topic, and less emphasis on actually doing something about that. So this would hopefully could be sort of a vision for the future. We have ongoing, just as a concrete example, we are participating in an ongoing Horizon 2020 project called Vax Trust, which both combines sort of two of these blue boxes you have here. We look at barriers and enablers in low vaccination populations, and based on this knowledge, we prepare a kind of a training or support for healthcare workers or professionals to encounter these issues. Just as an example of how the issues I just mentioned before could be tackled in the future better. Thanks.
It's a great example. Thanks very much. And I fully agree with you that there's so much research going on, and we understand kind of what the research is saying in terms of what can be the drivers of low vaccination coverage, but what to do about it is so difficult. And actually then how to involve all the relevant stakeholders, both within a public health organization, then you're talking about also the communication teams, not just the scientific teams, but also the broader stakeholders that work much closer to these low vaccination communities, for example. Søren, the final word is with you. One or two concrete steps before we open up for questions from the audience.
Now it can be heard also, perhaps. I'd also plan to mention the importance of keeping the various arenas for meetings, common discussions, joint discussions, and so on, and further develop them. But it has been extensively covered now by Karam and Jonas. So finally, I'd just like to add that what we're here to present and discuss today, all the nice and important work that has been done through this joint action, it's important to further build on that, not to stop here and just report and move out and do something else, but to utilize what has been accomplished through the JAV that relates to much of these 13 themes and other issues as well. So it's just a kind of a general reminder to all of us. Thank you.
Great, thanks very much to the panel. Olivier, do we have a couple more minutes for any questions from the audience? A couple more minutes until 15:15. Are there anyone having a question from the audience or from the participants online? I think the questions can go to any of the panelists. Yes, please. Olivier, do you have a microphone?
Thank you very much. It was very interesting, and also this topic you're speaking with Bear Owen, representing European Specialist Nurses Federations in Europe, and I really want to push a little more good news. I see on in the very first slides that there is not much collaboration, and I see on the bigger countries in the west, on the east and the Balkan, I see a very different color pattern, where there is far more collaboration. So I really need to stress always good news. And if we're talking about vaccines hesitancy in the healthcare professionals, this is a really big concern also in our group. But we really make some really big steps, and we constantly doing a lot of surveys and also windowing the importance of vaccination, not only pushing the uptake, but also the knowledge, communication, and also these kind of this kind of interventions. And I had a last remark, but just slipped out. Oh yeah, we do represent about 5 million nurses, and we are a group of cross-national nursing organizations, diabetes, rheumatologists, nurse directors, educators, intensive cares. And we do have a program on vaccination and also including AMR and infection prevention. And for us, it's very important to connect with the national organizations, but this is a huge barrier for us. So we constantly try to engage with national representatives, national organizations, but as professional organizations, there seems to be a very big gap just only the figures, but also the health professionals doing the work. So I think this is really a very important event, and I was also there with the first meeting in September in 2018. So I'm really pleased to be here, and I also follow the remarks in the opening sessions that there's still a lot to do, and this is our call. But I would like to see that the healthcare professionals are more able to work with national representatives on this. Thank you.
Thank you. Very important comments there from the nursing side. Any more questions or comments from the audience here or from the participants online? Very welcome to ask questions, make your comments.
Not for the moment.
Not, oh, no.
Not for the moment.
Not for the moment. Okay, perfect. But then we'll close the session. Thank you very much.
So we will resume our day of presentation and discussion of the achievements and results of the EU-JAV. And now we will have the team who are focused on vaccine supplied and EU-wide anticipation and preparedness. And for this, I will leave the floor to Karianne Johansson from Norway, Antonietta Filia from Italy has heavily participated to this team, to this achievement, but she could not be there today.
Yeah, I will use this one. Thanks a lot. And good day. So I will cover the talk on the work package 6 on vaccine supply and preparedness. And basically this work has been taken up by 2 teams, the Italian National Health Institute and the Norwegian Institute of Public Health. And the background for vaccine supply and preparedness, and you must remember that this was really back prior to the COVID-19. It was back in 2018 and 2019, and COVID-19 vaccines and the purchase mechanisms we had didn't really exist. But still, vaccination is one of the most significant public health achievements, and thus national immunization programs really depend on adequate supply of high quality vaccines. So vaccine shortages then will be a very serious public health issues, as they can lead to missed opportunities for those who are going to be vaccinated, and also a greater risk of occurrence of deadly vaccine preventable diseases. The slide deck, which I'm covering today, is quite comprehensive, and also there are a lot of reports which have been published on the European Joint Action webpage. So I really recommend you to read them fully and truly on the webpage. But I will highlight some key topics and maybe also focus more on the recommendations and the future outlook in terms of the experience we now have with the COVID-19 vaccines. But the work package was divided in two different tasks. The first one was to look into mapping vaccine needs and demands. And that was the Italian team that looked at shortages in Europe. They also looked into financial mechanisms for vaccine procurement and also looked into what kind of guidelines or procedures did the national institutes or the public procurers have in place. And the other task was led by the Norwegian team. And we wanted to look into, in case there is a shortage, if you need to really exchange vaccines quite quickly with another member states, what kind of tools would be useful? What kind of mechanisms could we use? And then we also wanted to ask the question to the member states if they wanted to have like a data warehouse to review all the supply in Europe, if that would be helpful in case you needed to exchange vaccines. So the first task, the methods, I think we used basically the same type of methods. We did a lot of surveys, and we also did literature reviews, and we also used the meetings which took place, and also workshops with some selected stakeholders. The first results from the Italian team, they looked into shortages. And this is back in May 2019. I think the review they did was from 2016 to 2019, so they covered 3 years. But back then, it was 28 countries which they surveyed, and 21 of them responded, and 19 of the countries actually said that they had experienced at least one shortage in their immunization program. And the median duration of the shortages was 5 months. And 6 of the countries back then reported ongoing shortages. And if you look to the map, it's on at least on my right side, it's probably on yours right side as well, you can see that by the color that some of the countries experience more shortages than others. Italy, for instance, France, and Greece and Latvia back then. And the vaccines in the schedule affected by shortages was the diphtheria and tetanus containing vaccines, hepatitis B and hepatitis A. And the most commonly reported causes of shortages was production issues and global shortages. And this really also reflects the fact that vaccine production today is global. There are very few suppliers and they are manufacturers of a large scale. And also some pointed out that it was a higher than expected demand, which reflects back to what kind of forecasting procedures do the country have in place to expect what is the need. The Italian team also asked the impact of shortages on vaccine services, and some of them said that they had then to use alternative vaccines to temporarily change the immunization schedule. And they also asked the stakeholders' views about these shortages, and their feedback was really that timely communication between supply and demand is really fundamental to avoid and mitigate shortages. And these results have now been published in the Vaccine Journal, actually February this year. The second results from the Italian team, they looked into financial mechanisms for vaccine procurement. What kind of financial mechanisms did the member states view and their opinion on that? And the main findings from the report on financial mechanisms was that most of the European member states said that the national vaccination schedules were entirely funded by the national or subnational governments. And they actually said that the financial mechanism of vaccine procurement seemed to function well in general. And most countries used annual budget planning cycles, not long-term, which is, I think, is a key finding. It's quite short-sighted, the way they plan for the budget. But it also maybe reflects that the governmental budgets is yearly and annually is not like a strategic long-term budgeting plan in most countries. And the majority of the participants, they were also favorable to joint procurement of vaccines during serious cross-border health threats. And of course, I think they are maybe even more favorable to that part now. And they also said that other forms of cross-border collaboration, that lending and exchange of vaccines should be further encouraged. The last work on the Italian team to estimate vaccine needs and procurement in Europe, I think that what you could say that the countries who reported that forecasting vaccine demand for like annual budget planning cycles is something one could maybe look into, that maybe one should do more long-term forecasting. And most countries did not actually have written procedures for forecasting in place, and they used a combination of a size of the target population and also previous year consumption methods. And not all countries reported using electronic tools to focus vaccines. Even those tools exist, and you can readily just download them. For instance, for like UNICEF have a forecasting tool which could be used by all countries. And interestingly, also many countries reported difficulties in estimating the numbers of individuals with chronic medical conditions for which specific vaccines may be indicated. And that is also something we've been seeing with COVID-19 vaccines, particularly in the early days when we really had to prioritize very hard, and we had to figure out who were the risk populations. And at least in Norway, we really struggled to figure out how could we identify these risk patients. By age is easy, but if you want to look into medical conditions, we had to use the GPs to identify the risk populations. But then, of course, to handle the vaccines and the risk population at the same time was quite difficult. And also the Italian finding was that vaccine hesitancy is difficult to estimate, of course. And maybe even further in the future, it will be difficult to estimate. And also vaccine wastage when you don't have like a one dose, but if you have multiple doses, then you really have to organize the logistics around the vaccination. It could be really difficult to estimate what kind of wastage do you have. And also the countries reported to interact with their night tags during focus, but it was only 3 of them actually used the night tags. So to conclude the Italian work, I think they've really done a comprehensive view of vaccine shortages. They looked into financial mechanisms on what you need to enable vaccine supply for immunization programs. And I also think that they pointed out that it should be a continued dialogue between manufacturers and health authorities, also including night tags. And it's really needed to everybody to work along to have more accurate forecasting of vaccine needs. The recommendations and the future outlook, which we also could discuss in the panel debate, is that more research is needed on the cause of vaccine shortages and how the different causes interplay with each other. And there is a need for all countries to have an immunization supply chain improvement plan in place. There should be timely communication between the public health authorities and NITEX and manufacturers, as I pointed out. And also procurement and tender mechanisms should be improved by taking into consideration multi-source suppliers. And I think I did not mention that, but a lot of the countries mentioned that they very often only use price as a criteria for the tendering process, which of course is something one could look at. Further recommendation was a longer-term planning of vaccine demand is strongly recommended. And this is something I will come back to in the Norwegian part, but the sufficient stockpiles of vaccines at national level need to be in place, including an emergency. It was not so many of the countries actually said that they had an emergency stock for their national immunization programs in place. So this is the Italian team, and Antonetta, as Olivier said, is not able to be here today because she had a sudden loss of a mother. But you should just contact her in case you have questions to the reports. The second part of this work package was if you need to exchange vaccines quickly, what are the mechanisms we have in place and what could we recommend for such mechanisms to be in place in the future. And what we did, we also did surveys and literature reviews, and we used the workshops, and we had 2 reports. The first one was focused on understanding the mechanisms to exchange supply and demand. And we also tried to look into more depth, because that was really one of the tasks back then when we built this joint action, was the idea of having a European data warehouse where you could have the overview of all vaccines. At least you should have it like a data tool, and not, it was also some ideas to have like a physical stockpiling. And I remember back then, when at least our team said this is not possible, we can't have this data warehouse, and nobody would actually want that in the future. So we will see in the future how it ends up. But I really want to point out one thing first, and I think that is really something we've seen with the experience with the COVID-19 vaccines. That exchange of vaccine stocks in case you really need supply, or if you have surplus vaccines. It's not a straightforward process, and it's quite complex. It's easy to talk about, but when you want to do it in the Ministry of Health or in the National Institutes of Public Health, it's quite complex and bureaucratic. Because you need political commitment, and the member state must have in place a proper mechanism to accept the vaccines, and you need to have capacity in place to accept the vaccines. And there must be regulatory approval, because the regulatory approvals are national. It's the member states who do the regulatory approval. You need to have an import approval, you need to have indemnification in place, and also liability agreements. And particularly for emergency use vaccines, you need to have liability agreements. And these processes might seem like very detailed management for some and like a hassle, but they really must be in place before you can sign any legal binding purchase order, before you can transport any goods. So this was maybe my future outlook first. and then to the results of our task. This is also back in 2019, before the COVID-19, but back then they said in order to exchange and to ensure sufficient supply, you really need to have early warning system from suppliers of manufacturers and potential stockouts. And you need to have a sufficient stockpile at the national level, and you also need to have an emergency stockpile. Looking back to the COVID-19, we have struggled when we have the stockpile in place to actually to donate surplus vaccines when they are in place. It's easier when it hasn't touched the Norwegian ground. That's also something maybe we could discuss if you need to exchange vaccines. But of course, you need an emergency stockpile if you have wastage, if you can't, if something happens, if you need to have quickly vaccines in your own country. And in order to improve focus, this really reflects also a lot of the work by the Italian team, that long-term vaccine focus from government agencies and procurers should be in place. There should be timely input from parties. And also they pointed at harmonizing labeling of vaccines is really helpful if you want to exchange vaccines. And on the COVID-19 vaccines, there have been European labeling, so it's very easy to just switch the goods. We asked them about the preferable recommended mechanism to weight them if you want to exchange vaccines between European countries. And it was really, they said, we want a rapid exchange mechanisms, we want SOP, standard operation procedures, and we want to have templates which could be easily just used in a national context, and harmonized labeling, and you need to sort out the liability protection. They were not so keen on the European data warehouse. They more thought, well, maybe we could just have a voluntary option mechanism. And some also pointed at the need to agreed compensation mechanisms. And specifically, when we asked about European sharing of data on vaccine supply, if it would prevent shortages in Europe, they was really like, no, yes, we don't know. But interestingly, they said that if we should have a data warehouse, they should focus on priority vaccines. It should be rarely used immunoglobulins, antitoxins, specific vaccines, and emerging infectious disease vaccines, outbreak vaccines. And back then it was Ebola vaccines. I guess if we ask today, COVID-19 will be there, or maybe future pandemic vaccines. So in the last work, we wanted to look into, because it was the task of the work package. So we had to explore further options of this data warehouse, even if the member states was reluctant to it. So we looked into if you had like 3 options, the voluntary sharing, the regional virtual stockpile, because we had experiences with the Nordic countries sharing data, or a virtual European data warehouse. How could it look like? And we also followed the ongoing discussions between the European member states in the Health Security Committee, because they worked on standard operating procedures and also simple exchange mechanisms. So this was back then. And what we have designed is a kind of a framework for if we want to take this further in a joint work. We really need to look into the different options. What could the voluntary sharing mechanism look like? What could be the functionality? What kind of agreed mechanisms and existing systems and templates must be in place? What would be the scope? Should it be the scope which was identified back then? Should it be more on surplus vaccines? And also the risks and legal liability. And if you move further to sharing data, you also have to handle information security, and you also have to handle GDPR and liability in a more extensive way. So our recommendation is, it might not look like this, but this is really the nitty-gritty details you have to look into in the future. So what could we conclude, and what is the added value of this work? We believe this, at least we have a better understanding of important mechanisms to ensure sufficient supply and size of stockpiles. We know there was uncertainties in the European member states and their opinion on the need to share data, and analysis have identified future options. And we also think that maybe in the future, the countries will be looking more into pandemic preparedness, vaccines for epidemic outbreaks. And that is also something which HERA is setting up at the moment. So we recommend further work on sharing data information on vaccine supply. We actually say that we were really uncertain to have a data warehouse. You should actually say that maybe we should just have a status quo and work further with the experience we have of the COVID-19 sharing mechanisms, but really focus more on using the harmonized labeling of vaccines as a useful tool for all vaccines in the future, and to develop a standard operating procedure which all member states could use and share. Finally, we also think that the common procurement of COVID-19 vaccines has additionally provided the member states a lot of experience with sharing mechanism for surplus vaccines during an emergency, because at least in these days when we have a lot of vaccines, it's a surplus vaccines, it's a portfolio of vaccines. There are different vaccine schedules in the different countries, and also different ways to handle them. But we have now experience with the global sharing mechanisms, the global collaboration with COVAX, which has been very difficult. It had actually been more easier for the countries to put in place bilateral donations and procedures between countries to accept the templates and liability agreements. But I think that global collaboration COVAX has been improving and improving as they have gained more experience with that. And I think that these new experiences will affect the member states' view on these questions. And I think that our results should be considered in this context as well. And this is the team from Norway. And this is just a name. So I just say thank you. I think that was my presentation. And this is just a name. So I just say thank you. I think that was my presentation. And now we open up for the panel. I think all of the panelists are online. So I'm not sure if I can see them, but maybe they could. Truus and Michelle. So maybe if you could invite Michelle Stoffel first, and maybe interest if you it's from the vaccine producers.
Okay.
So Michael Stuffel, maybe you could comment on this talk and the topic and your reflections on supply in Europe, and then we can open up for Truus afterwards to comment. Thank you.
So, Karen, I'm sorry, it breaks in the connection. So, just to confirm, so the question is for me?
Yes, if you want to comment on your view on supply and exchange of supply from the manufacturer sides in Europe and your experiences.
Yes, so thank you very much. I think the results that you have shown in the presentation are very interesting, and basically they are confirming the position of Vaccines Europe, so which is the association of vaccine manufacturers operating in Europe. When we see the results, I think there are important messages probably which would merit further reflection, as you said. One of them being the fact that few countries only have a mechanism in place to forecast the demand on the long term, which is certainly something problematic in the sense that we have very long lead times for the production of vaccines, as you know. So typically, the majority of vaccines have lead times between 18 months and 24 months, but the complex vaccines can have lead times of production of more than 3 years. So you can imagine immediately that manufacturers need to have a long-term visibility on the future demand. The recommendation also, which is made to have a continuous dialogue between authorities and manufacturers is certainly something which is very important. Another topic which has been mentioned is about the fact that many countries do not have sufficient stocks today. That's probably true, but it's also a concern for Vaccines Europe in the sense that if all countries now start to build their own stocks without any consultation between countries and without any consultation with industry, the situation might be even worse, because we know that today there is a tension on the supply of different vaccines. And so what will be important is to have a dialogue between authorities and individual manufacturers and a coordination if we want to go that way, i.e. that countries build their own stocks. That should be progressive. We should have time to build such stocks. And you mentioned a very important observation, which is about the lack of harmonization of labeling. I want first to react saying that this concerns mostly the old products which were approved many years ago. The new vaccines have been approved via the mutual recognition procedure or the centralized procedure, and therefore, in terms of content, the content of the label is the same whatever the country. There is a point that you did not mention in our view, which is particularly important, is to move to electronic leaflets, but also to move from diverse packs to a common EU pack if we want to have more flexibility in supply. That will be certainly very important for member states if they want to exchange a product, but also that will be very important for manufacturers to address the problem of shortages. It's definitely one of the strong recommendations which is made by industry. So could we replace the paper leaflet by electronic leaflet with all the advantages, like providing the information in all the languages with and so facilitating the access to information to people who are vaccinated. And even we can imagine in a crisis like the crisis in Ukraine today, we could even very easily add, for instance, Ukrainian or Russian as a language during a period of time of a crisis if we move to electronic leaflets. Having a comment pack as well would certainly be also something of added value. If you just think about the serialization, we still have two standards in Europe, and basically the move of boxes is possible today, but it's not so easy. And we have certainly important learnings from COVID, for instance. With COVID-19 vaccines, authorities have accepted to use the common jet-in across countries, and we see that this is possible. So there are certainly learnings, and there are certainly there is certainly a need for reflection on how we could improve the packaging labeling requirements to facilitate the transfer of products between countries. I will stop here. I don't know if you have other questions for me.
Yeah, I was maybe inviting Truus de Graaf from the Dutch authorities to also comment on their work, on the work package, and their maybe the perspectives from your side. Is Truus online as well?
I am online. I'm not sure if you can hear me.
Yes, we can hear you.
Yeah, we can.
Ah, great. Well, it was very interesting to hear everything we have managed despite COVID. Lots of results. Thanks, Karianne and Antonetta for managing this ambitious project. Also, due to COVID, the world has changed. Most curious we are now, how would countries react to the questions asked for in the surveys in the field of COVID. And we anticipate, but we don't know for sure. So what we see is that with COVID now, at the moment, we have the opposite of what we had with vaccine shortages in the past. At the moment, there's a surplus of vaccines, and it's almost impossible to donate them to the countries in need. So totally different world at the moment.
Yeah, but if you look at, because I think we discussed it back, at least in Norway, with the ones who are doing the tenders, that do you see there are any particular vaccines in the future where we could use this joint procurement mechanisms like we did with the COVID-19 vaccines? Of course, the pandemic influenza vaccines is already a joint procurement, but are there other vaccines, and what can we learn from it? I think it was really interesting to see that we have a portfolio of vaccines, particularly when you have emerging vaccines, where you actually don't have a full license, it's an emergency license. And then you really need to have a range of vaccines to see what works best real life. And you have to be able to change them rather quickly if you have a safety signal, for instance. Mm-hmm. I don't know if you want to comment on that as well.
Yeah, I think it's very promising what in a short while we have established as European countries, first in procuring COVID vaccines, but at the moment still COVID medication. And we're still doing that together. I think it's promising for the future, and I think HERA will take over at a certain point, and also help us prepare for next infectious pandemics.
don't know if Michelle, do you have any comments to that topic? Thank you.
Yes, so thank you, Karian. Vaccine's position is that joint procurement should be focused on emergency situations, very special situations, and we have seen the added value in the case of COVID. But what we believe as well is that for other vaccines, so the vaccines which are used in routines, there is certainly also a need for improvements in terms of the current procurement practices. I mean, what you have shown, you see, the fact that many countries have annual cycle, it's an example of, again, the kind of challenges that we are facing. If again, I take into account the duration of production, certainly a 12-month cycle is not long enough. There are other aspects also which are very important if we want to reduce the risk of shortages. The fact to have tenders with only a winner, you see, and not split tenders where you can have several companies, certainly represents also a risk, as you can imagine, when a manufacturer is losing a part of its market. This may have consequences in terms of maintaining a production, and therefore we can certainly also have a risk that some manufacturers are leaving the market. And so there is certainly a need for a reflection also for routine vaccines, how to have better tender processes in place at national level.
Thank you. I think I will open up to the audience. We have 2 minutes left. 1 to 2. So are there any immediate questions among the audience here today? No, everything is super clear for the future. I don't know, Olivier, if you want to. Yeah. Then I just say many thanks to ones who were able to participate virtually, and also to the audience who didn't have any questions. So then we'll move on to the next topic.
What do you think about EMA and in the future joint procurement, the role of EMA, because we have now an agency for vaccine, and the release mandate of EMA, I think they have a mission on this. So what is your thought about the role of EMA for the future?
For the European Medicine Agency? I don't have any answer actually, but I think at least they have a lot of involvement during the COVID-19 vaccine. It's been really very important that they have been able to engage very quickly, also with the National Public Health Institutes, if there was an event, if we had issues which we had to sort out. So maybe they should be more tight, but particularly for emergency use vaccines, I think.
Yes, just one quick comment. We will have Marco Cavalleri as a panelist for the next session. So
we could ask it to him.
Yes.
Yeah. Okay, thanks a lot. Then we just close this session and move on to the next one. Thank you.
Thank you.
Okay, thank you, Karian. Thank you again for the panelists who commented with you your results and Antonieta's results. And now I'll give the floor again to Karwa Madalali from the ECDC, and he will have a word on the ECDC work to support COVID-19 vaccine strategies in European Union.
Thank you very much, Olivier. I hope you can hear me, and I hope you can see my slides well.
Yes, but it's not in the show mode. We see your slides, but not the...
Let me try again. Is it better now?
Perfect.
Very good. Thank you for inviting us once again to address this to the final event of the joint action. It's very exciting to learn and to see everything that has been produced during these 3 years, and especially the amount of and wealth of knowledge that has been created despite the fact that a lot of the work has been undergoing during the pandemic. So the goal of my presentation here is to show you a little bit of the work that we have been doing in support to COVID-19 vaccination strategy rollout and deployment in EU member states. This is really what has kept us busy, of course, over the last 2 years. So I will show you the work that we have been doing and some reflections on the way forward and how we see the future, of course. To start with, just a little bit of background on the policy and legislative context in which we operate, which I think everybody is well familiar with. The Council recommendation that were approved in 2018 continue to be critical. And the instruments that they have called for set up at European level are instruments that we have been able to leverage and to use during the time of the pandemic, and to really enable us to put in place platforms and structures that we wouldn't otherwise have had, and that have revealed themselves to be very critical for the exchange between countries and for the work that we have been doing in trying to support member states in setting up their COVID-19 vaccination strategies. Obviously, throughout the pandemic, the Commission has come up with a number of policies that have been made public through their Commission communications, outlining essentially the new actions or the interim actions during the evolving stages of the pandemic that we also as agencies, including ECDC, were required to undertake. And that obviously has significantly affected the work that we have been doing. And then finally, last but not least, and this is what is coming next, is the proposal as part of the European Health Union to amend the regulation that establishes ECDC. And this is, of course, a critical document for us. It's what is going to mark the future and how ECDC is going to operate following the approval of this new regulation, and building on the experience and the way that we have been working in a large way during the pandemic. So we started on, of course, very early on, even before the vaccines were available, to try and support countries in reflecting on the aspects that were needed to develop vaccination programs for COVID-19. So the different components, the different categories that countries were to take into consideration in order to have a successful national and EU level COVID-19 vaccine deployment plans. We've also been working with countries to develop prioritization strategies, particularly in the initial stages of the rollout of the campaigns, considering the limited supply that we knew would be characterizing the early phases of the rollout. We've been working together with the countries, together with the Commission and the Health Security Committee, on a number of stress test and preparedness exercises that were really geared to try and prepare more from a logistical side and operational side to prepare for the rollout of these vaccines, taking into consideration the specific characteristics that we knew they would present and the challenges that would come along the supply chain. Since the early stages of the rollout, we've been regularly monitoring what have been labeled as the National Vaccine Deployment Plan through the so-called ISA process that have been established by the Commission. Essentially, we've been producing regular reports with a high frequency that were aiming at documenting vaccination strategies, the evolution in vaccination policies during the rollout throughout the different stages of the pandemic, and informing on specific initiatives of different situations that individual member states were facing. And we've been publishing 8 editions so far, and a 9th edition is due to be published by the 31st of March, so at the end of this month. And these have been critical because we believe that this documenting of the different national vaccine deployment plans is what has really enabled us to learn what structures and mechanisms the countries have put in place to meet the challenges of rolling out these mass vaccination programs, but also documenting a lot of the good practices. And one of the future things that we aim to look at within our program is to see what learnings we can draw from the way COVID-19 vaccination programs have been rolled out going into the future, and what can be transitioned and applied and used as a lessons learned for the implementation of routine vaccination. Our NITAX collaboration platform has been very critical for the dialogue and the exchanges between the countries. And my colleagues that work on this project have provided me here just with a list of the main topics that we have been dealing with throughout the pandemic. In 1.5 years, essentially, we've been holding more than 20 workshops or webinars that have been dealing with different topics just as the situation was evolving. And the focus here has been on the rapid sharing of information, rapid sharing of evidence, and rapid sharing of country experiences to try and understand the scientific rationale underpinning different strategies and different approaches undertaken by the countries. And this very much goes back to the discussion that we were having earlier with regards to cross-border collaboration, where we've really tried to play our role in facilitating this early on dialogue and sharing across countries. This has been a little bit different from the original intent that we saw for the NITACs collaboration, but we believe it has been also a key learning experience that we will take forward in reflecting about the future of how the NITACs collaboration will be sustained by the ECDC moving forward. We provided a large number of technical guidance documents on vaccination strategies throughout the pandemic, on the benefits of full vaccination, the implications on non-pharmaceutical interventions, which have been regularly updated at different stages of the pandemic, guidance regarding partial vaccination, vaccination following a previous infection, heterologous vaccination schedules, but also providing information on public health considerations for the provision of additional COVID-19 vaccination, on boosters, the vaccination of children, and the vaccination of adolescents. And all of this information has been regularly produced, also in close consultation in many instances and in discussions with the NITACs themselves, which have helped us to come up with the final public health considerations that we've issued at European level to inform the next stages of the vaccination strategies at European level. A critical item that we've been able to work on as well has been the establishment or the launch of the establishment of a strong infrastructure across Europe for the monitoring of COVID-19 vaccine effectiveness and impact. So the establishment of infrastructure to enable us to really study how these vaccines perform in real life. And this has been possible thanks to an additional contribution that the Commission has granted to the ECDC of about 7 million a year, a contribution that is expected to continue through to 2026, and that we have been implementing through what we call VEBIS, our Vaccine Effectiveness, Burden and Impact Studies project, where we started 4 multi-country studies on vaccine effectiveness in the settings and against the outcomes that you see listed in this slide. This will be critical also moving forward into the future. As part of the new mandate, the Commission has specifically asked ECDC to work more closely with EMA on the real-life monitoring of vaccines in the post-authorization phase, vaccine effectiveness, vaccine safety, and this will continue to be a very important flagship area of work that I think many of us have been advocating for, particularly in terms of sustainability of funding at EU level, and that we hope we will be able to even build further upon. The initial scope of the work is on COVID-19 vaccines, of course, due to the emergency, but the plan is that this infrastructure be expanded and take back other priority vaccines as well as part of the routine immunization programs. And this brings me exactly to the work that we have been doing in joint partnership with EMA throughout the pandemic. We've been working closely with EMA all throughout, particularly on the topic of vaccines and on the topic of immunization. But I think we can safely say that this collaboration has been particularly strengthened during the pandemic. And we've been able to work in trying to bridge in a more sustainable way and establish a more bespoke dialogue between the public health authorities and the regulatory dimension of vaccine assessment. And this has been possible by bringing closer the two agencies and by bringing closer the networks of the two agencies. We've been able to more regularly participate in EMA regulatory meetings, and EMA has been regularly part of our NITACs meeting, particularly on the discussion that concerned the safety of the vaccines that were being authorized to fight COVID-19. But we've also been able to launch a first pilot in relation to what I was mentioning before, in relation to the enhanced post-marketing monitoring of COVID-19 vaccines, with ECDC primarily leading on the effectiveness studies through the VEBIS project that I showed you just in the previous slide, and EMA primarily leading on the safety side. However, throughout the pandemic, we've also been regularly working on issuing joint communication that have been critical on several topics at different stages of the pandemic, bridging between the public health and the regulatory side of the evolving situations. And these were communication at large to the public, to healthcare professionals, to stakeholders, and to the member states to really strengthen our joint voices and united efforts to have consistency in the recommendations that we believe countries should take in the further rollout and implementation of COVID-19 vaccination program. And we expect this partnership, of course, to continue along these lines. And as I was mentioning, because of this request on the ECDC and also on the EMA as part of the new mandate to work more closely on the post-authorization monitoring of vaccines, we are currently working on carving out a collaboration agreement and trying to outline what will be the division of tasks and the principles of collaboration in this area between the two agencies. But this is definitely a game changer that we've experienced, bringing together this public health and regulatory dimension, which was very much needed at European level. In essentially no time, we've been able to also establish what we call the ECDC COVID-19 vaccine tracker to enable us to monitor the rollout of COVID-19 vaccines. And this has been possible largely thanks to the collaboration and the great effort of all of the member states that have helped us in setting up this system and in reporting the data in a very timely way to ECDC. What this allows us to do is to develop a proxy of vaccine uptake by receiving information from the countries on the vaccine doses that were received through the advanced purchase agreements and the vaccine doses that were administered. And we've been able to create a very rich database, a very rich platform that you find on our website, or that you can search just by typing in COVID-19 that enabled us to monitor not only what was the uptake for different target groups by doses, by country, etc., but also enable us to understand what was the speed of the rollout and eventually discuss specifically and individually with countries the specific challenges that were being faced. So the COVID-19 vaccine tracker has a large number of variables, and the countries have been working relentlessly to help us to work on the completeness and the accuracy of these variables, but also to ensure consistencies with the data that is published at the national level. And we are currently in a reflection process to see how we can transition to a lower frequency, decrease the burden on the member states, decrease the burden also on ECDC side, of course, in terms of the data that we upload and that we provide through this tracker. This data has been critical, and it has given us the opportunity to develop a very rich number of ECDC outputs, not just the tracker itself, access to the downloadable open data, specific country overviews, and also the so-called vaccine deployment report series, as well as infographics that have been used for social media sharing and dissemination. This system has been put in place in a very rapid way to rapid understanding of what was happening for the rollout of COVID-19 vaccination programs. But we believe that this is a model that we hopefully can use and can tie in also for the further reflections on how we can expand ECDC's ability to collect coverage data in the future for other vaccine preventable diseases, which is a critical part of the new mandate and what ECDC is asked to do in the future, even asking ECDC to have this data not only at the national level, but also at the regional level. And we certainly have a lot to learn and to see in terms of what we can do, also taking up the discussions that have taken place earlier this morning with regards to your pilot in using IIS, which we believe is critical, and we intend to take forward that discussion with the work package leaders to see what we can do in that area in terms of sustainability. And of course, last but not least, a few words on the area of vaccine acceptance. I will not spend too much time here because I know that you will be discussing this further in the context of the work that has been done by the Joint Action Work Package 8, Jonas, Antonietta, and the other colleagues, which we believe is great work that we can also learn from and that we need to reflect on in terms of how to take it forward. But specifically when it comes to the COVID-19 vaccines, we have seen new things, we have seen new facets of the issue, but at the same time, we are also mindful of the fact that the common concerns and determinants of low vaccine have also been very much in line with those that we have historically seen for other vaccines, particularly in terms of the safety, the perception of the disease, the effectiveness, the differences in behavior across different age groups, etc. And we've also seen that these issues around hesitancy, just like they are for many of the other vaccines, tend to be very complex, context-specific, vary across time and across place. So this tells us that the determinants and the categories along which we need to work remain the same. Of course, with the fact that we've had an exacerbated situation due to the increased attention on the COVID-19 vaccines, the novelty of the way these products have been developed and how they function, and also the more rapid spread of fake news, which have presented, of course, a number of challenges. But again, another confirmation that we've seen of what we knew already from peace times is that healthcare professionals at large, doctors, nurses, and pharmacists do remain the most trusted source of information to members of the general public. And this has been confirmed on and on by national studies that have been undertaken during pandemic, but also by the Eurobarometer studies that have been undertaken at European level. And this reminds us of the importance of continuing to invest in this area, or to also finding out more about the work that has been done by our Belgian colleagues in Work Package 4 in that regard. We ourselves at ECDC are endeavoring to invest in this area, particularly frontline healthcare workers, to training activities, to try to bridge the gap in vaccine acceptance, to increase motivation for vaccine uptake using motivational interviewing techniques to upgrade the skills of frontline healthcare workers, and also to upgrade skills in fighting misinformation. And we are working currently on the development of e-learning modules that are being piloted, being finalized, and we hope will be released and available already by May. And last but not least, a word about the European Vaccination Information Portal. This is our ECDC coordinated platform that we developed jointly with EMA and with the European Commission, called for by the Council recommendation from 2018 that I mentioned at the beginning of the presentation. It just reminds us of the importance of a clear and consistent communication to the general public. And this is a special platform that we developed separately from our corporate websites, where the target is really the lay audience, and we try to talk in a simpler language to the lay audience. The objective of this website is not to be a promotional website, but is really to provide as accurate, authoritative information as much as possible with the latest evidence that is available on vaccines and vaccination in a non-technical language. It was launched in April 2020, and it has been, of course, a critical tool that we've regularly updated during the pandemic, specifically for the sections related to COVID-19 vaccines. The advantage of this webpage is that it's available and regularly translated in all of the EU languages. And for us, the goal is really to increase the consistency of information that is available on the online space regarding vaccines and vaccination, and to corroborate the information that we know all of you, all of the public health authorities at the national level are endeavoring to provide to their citizens and members of the public. And here are just a few concluding thoughts and reflection from my side, which is really about the fact that sustainable and resilient vaccination programs with a solid infrastructure during peace times are critical to the success of vaccination in crisis times. And we've seen this very clearly throughout the pandemic, with countries doing best when having in place the most solid infrastructures and the strongest sustainability to be able to monitor the performance of their immunization programs already in peace times. The joint action on vaccination has clearly built an incredible wealth of knowledge and recommendations on how we can strengthen the sustainability of immunization programs in peace times. And we believe that work must be done, certainly, to integrate all this knowledge into EU and national efforts. And as I was mentioning earlier, it has not been possible in many regards to have this discussion on sustainability for several of the work packages of JAV, but ECDC will work even after the joint action is officially concluded to better understand the products that have been produced and to see what is it that we can take forward, what we can learn from. And certainly we can learn from the COVID-19 vaccine rollout experience overall in general. It has broken down critical barriers, we believe, in the planning, monitoring, and implementation of vaccination programs. And there is no reason for going back to the previous status quo. So we certainly have to take stock of what has rapidly been put in place and see how that can be transitioned to the implementation of routine vaccination programs. The forthcoming amended ECDC mandate will empower us to do more in this area, to continue to strengthen work on immunization, better integrating it into the prevention, better integrating the work on vaccination on the sustainability of healthcare systems, more specific work on vaccines as part of preparedness chapter, and of course, more work goes on the routine monitoring of national vaccination programs, particularly earlier on monitoring vaccines in the post-authorization phase, but also monitoring of vaccination coverage. And finally, we must continue to understand and document the enablers and barriers of successful implementation of vaccination programs and continue the dialogue across all stakeholders. And I think the joint action has done a great job also at documenting practices. And this is something that we believe is fundamental for cross-border collaboration, as we were discussing this morning, and is something that we would for sure continue to take forward as ECDC. Thank you for your attention.
Thank you, Karam. Thank you for this very interesting and large presentation. Do you have finally a bit of time for some questions?
I have just 3 minutes.
Okay, I have just a remarks. I was very interested in what you were saying regarding the work with all the NITAGs in Europe. And indeed, all the sessions that have been organized on those different topics related to COVID-19 vaccines. You have already said some words, but can you please tell us how ECDC is imagining the 2 coming years or the 5 coming years in words of NITAG collaboration, harmonization, Europeanization?
Yes, thank you for this question. We are currently just in the reflection process exactly about that. And in fact, what is happening is that we are reviewing the terms of reference that we had drafted at the very beginning when the NITAG collaboration started. For us, it remains critical, of course, to safeguard the independence of the work of the NITAGs, but also the understanding of the differences in vaccination strategies or policies that are recommended by NITAGs at the national level. But we want to work to increase the consistency of the way the common evidence behind vaccines is looked at and increase the cross-sharing of scientific products across NITAGs. And this has been an intent right from the very beginning. It has not been possible for us so far to implement the intended objective of the collaboration of NITAGs as it was meant to be because of the pandemic. But the pandemic has shown us also how we can more rapidly engage in dialogue and share information between the NITAGs, but also bridging between the NITAGs and the regulatory bodies, particularly in the situation of newly approved vaccines. So this is something that will for sure continue to be critical and feature in the next 2 years. And we are currently draft report that you have produced on the work on the NITAGs and the recommendations that have come out from the survey that you have done. And for us, a critical goal will be also to see how those recommendations can be taken on board and integrated going forward in the work of, in the revision of the terms of reference for our collaboration.
Okay, thank you for your answer, because I have the feeling that everybody among the NITAG are now used to have those meetings and will seek to have such meetings in the coming years. Is there another question or remark? No. Okay, so thank you again, Karam, for being there today and for this presentation. Thank you. Now I will give the floor to Karen Johansen and Jean-Daniel Lelièvre, and they will present the works they've done focused on vaccine research and development, prioritization and funding at a Europe scale.
Thank you. So I will present the work we have done with the Karian from the Norwegian Institute of Public Health and myself and other at INSERM regarding the vaccine research and development. So the objective of the European Joint Action of Vaccination is to find the ways to increase the vaccine coverage, and therefore defining research questions that aim to reach this goal is a key question. As liked by many speakers before me, we can find easily a great diversity of questions regarding this topic on increased vaccine coverage. Therefore, in a context of limited resources, prioritizing research questions becomes a necessity. Finally, the research funding system in Europe is still very complex, involves many actors, and is fragmented. The objective of the first part of this work package was to implement a process leading to evidence-based and transparent definition of research priorities in Europe in the field of vaccination research. This selection process must be carried out rigorously in accordance with best practices. And it's important to remind that this process focuses mainly on public health research aiming at improving vaccine coverage and not on classical RD aiming at developing, for instance, novel vaccines such as mRNA vaccine, for instance. Therefore, many of the subjects to be prioritized will therefore most likely concern epidemiology, human and social sciences, as well as implementation research. It's important also to define how to fund these research questions. So it was mandatory to define how to better understand different organization priorities and European member states' use of financing mechanisms and vaccine and vaccination research, to review on joint and collaborating European funding mechanisms, and finally to understand opinions on mechanisms to find and collaborate on shared fundings for common priorities on research in vaccination. So the first topic of the first part of this work package focused on prioritization framework. We have developed a framework based on an MCDA inspired from the Child Health and Nutrition Research Initiative by Rudens and collaborators. The general principle of this kind of framework is that each research proposition is assessed through a series of several steps. The first one was to select the managing team, to define the scopes of the process, and to find experts for the next step. Then we define research question. This research question was either a question which correspond to 3 to 5 years possible programs, or more specific question on a specific theme. For the collation of these questions, we perform a broad-based consultation and a direct solicitation of relevant experts, and we consolidate at the end a final list of research questions to be prioritized. The next step was the definition of different criteria related to these research question. We propose a first list based on the analysis of the literature of 8 different criteria, for instance, acceptability, equity, and so on. And we have a first list of experts to be able to consolidate this list of choice of criteria. Then we use another group of experts to weight these criteria, and it was done once again through a video conference with the experts. And the final step was the scoring of the research question. And I will show you the 2 different exercises we perform. At the end, we have a final list of questions. We weight this question using the different criteria, and we apply a score from 0 to 3. The bad one is 0, and 3 it's the good, the best one. And we submitted all the results to all the panelists, and at the end we have either a virtual or a face-to-face meeting to reach a consensus and to have a list of prioritized questions. We have published this methodology in an article published in Vaccine last year. So I will present you briefly the first exercise was based on the initial list of 4 different vaccine: influenza, measles, containing vaccine, HPV, and pertussis. And we decide to use this kind of vaccine because they could be applied at different age of life in children, adolescents, and elderly. We were able to collect 1,024 research questions at the beginning. Some of them were not relevant, or there are some duplicates. So at the end, we have 27 research questions. We make the final prioritization, and you can see here the 6 top questions that arise from this prioritization. And for most of them, they are directly related to the 4 pilot vaccine, to measles, HPV, pertussis, or influenza. But you have one question, it's more a general question, and it's quite interesting because we have already spoken about this topic. It's the involvement of other healthcare professionals in the vaccination, here the pharmacist. So due to the COVID-19, we obviously change a little the way we aim to make our second exercise, and we focus mainly on COVID-19 vaccine. Unfortunately, for this exercise, we are only able to have 35 questions, which is far lower than the previous exercise. 8 were general question on vaccination, and the other were mainly focused on COVID-19. You can see here the 6 top question of this second exercise, and some of them are directly related to the COVID-19 for the second, the third, and the 5th one, and the last one, and the other are more general questions. So at the end, we found that this kind of prioritization was quite efficient and relevant, but we are able to draw some lessons and to make some recommendations for the next exercise. The first one is to ensure that the diversity of expertise in the pool of experts are present, and associate as far as possible an external observer to ensure transparency, which was the case for us. The second recommendation, the scope should be present and explained as often as necessary in order to avoid submission of out-scope research questions, that it was the case at least for the first exercise, and to support an objective and appropriate assessment from expert. The third recommendation, and it's quite important because, as you can see, we have very few questions for the second exercise, is to, as much as possible, use every occasion you have, such as live events, conferences, and so on, to ensure good understanding of the scope and to be able to collect a great number of questions. That's a key point of this kind of methodology. Then, regarding the more technical aspect of this methodology, regarding the choice of criteria or the weight of criteria, it's quite important that there is no misunderstanding or unambiguous and understandable way to define this criteria and to choice and to weight this criteria. And finally, for the final ranking, we thought that this meeting need to be rigorously led to ensure that all experts express their opinion when necessary, and all research questions should be discussed. So I'll stop here, and I would like to thank all the members that have been involved in this part of the work package, and namely Florence, Francis, and Marie-Paul Kenny, and I will leave the floor to Karen.
Thank you. And then the second part, you can hear me now? Yeah, that's good. The second part of this work package is focused on financing. So when you have prioritized the research questions, you also need to look into how could you fund them. And we wanted to look into the European landscape of funding in vaccine research and development, but also on vaccination research. And we had 3 areas we looked into. We looked into national research organization, which naturally fund these areas. And we also looked into multilateral organizations, which we know were active in the area of vaccination research. And finally, we also follow the massive funding which took place on the COVID-19 vaccines. So first, when we did, back in 2019, we did a survey towards a national research organization. So of course, they did not fund COVID-19 vaccines back then, but they were really funding research and development in the early stage. It was general research and development of vaccines. It was basic research and preclinical development. And some of them finance research on influenza, pandemic influenza, and HPV, which John Daniel talked about, but very few of them supported any research on measles, mumps, or rubella, the older vaccines. And then some wanted to prioritize European funding on vaccines for emerging infectious diseases, vaccines to be used during epidemic outbreaks, and it was before COVID-19. We also asked them if they cooperated, what kind of cooperation mechanisms did they use, and what was needed to be in place to increase cooperation. And most frequently, they do joint calls, but also some bilateral and multilateral cooperation with other countries. But if they wanted to increase the cooperation in funding, they said that there was a need for clear guidance and options for collaborations, and it should really be built into the governance system. And there also had to be a joint evaluation and selection process in place prior to the announcement of a call. And there also had to be sufficient lead time to approve and agree on topics for calls for proposals and alignment on financial rules. And we asked them if they wanted to think about the potential future joint European mechanisms like JPI, if that could increase collaborative efforts in vaccine R&D, but only less than half of the organizations believed in such a tool for joint funding. They thought that voluntary mechanisms could be more suitable. But one area, most of them actually mentioned as particular need for collaboration within the vaccine field was late-stage clinical trials and phase 3, phase 4 trials. And this was before the COVID-19 pandemic. And then during the COVID-19 pandemic, we started also to follow multilateral organizations, and they are, as we all are aware of, very active in financing vaccine R&D. And I think we have one of them for the panel debate. And there are in the different stage of the cycle, some are very early and some are very late, more on financing vaccine stocks. But one interesting finding we had from all of these multilateral organizations was that very few of them actually receive money from the Ministry of Health or from the research organization, but a lot of countries use official development assistance, ODA, to finance this purpose. And we, of course, wanted to look into the joint action strategies, the vaccine hesitancy, stockouts, supply immunization systems, surveillance systems, and very few of these actually tasks are financed today, which we could discuss in the panel. And then we followed the COVID-19 vaccines, and we asked the question if this will be a paradigm for joint funding and new EU instruments. And of course, R&D funding for COVID-19 vaccines has been really at an unprecedented speed, and a huge and massive vaccine candidate development, a huge portfolio of vaccine, which was needed in this tragic pandemic we have been through. So we have, for Europe, we had a portfolio of vaccines which we could choose from, and we could also change according to the safety signals and what we saw with the portfolio. But we also then saw direct investment to public-private partnership organizations, and also really new instruments like the advanced purchase agreements, and also investing directly into pharmaceutical company and manufacturing, which we really didn't cover back then in our survey. And now in the future, we will also follow the implementation of the HERA, and they actually say that they will ensure development on procurement and key medical countermeasures, where also vaccines will be one of their topics, but on emerging pathogens. So our recommendations or take back home message from this work package is that as we see the landscape today, is really a great diversity of possible topics, and there is limited resources. And then as Jean-Daniel pointed out, that prioritizing research questions becomes really needed. And we think that more research on real-world effectiveness on vaccines, implementation of new vaccines in national public health programs, but also follow up on long-term safety and safety signals when you introduce new vaccines should be a prioritized area for funding. And the establishment of the HERA is key to ensure better vaccine preparedness in Europe, but it should not be at the expense of other important priority initiatives. So that is maybe one of the key messages we have today. And the Work Package 7, they have developed an effective methodology for prioritizing research questions, which we could use in the future to classify what areas should be prioritized and align on them. But then the success and impact of such a selection depends on the possibility of funding the research questions raised. And since still the research funding system in Europe is rather complex, is different Ministry of Health and money involved, it's still very fragmented. So we really think that in the future, if you want to have joint mechanisms for funding, more alignment, you should really work on that for the future. Thank you. And Okay.
So we opened the panelist session. For this session, we have online Marco Cavalleri from EMA, Melanie Saville from CEPI, and present in the room, Abdul Ghaffar from WHO, and Abdul have kindly accepted to chair this session.
Thank you, Jean-Daniel. So I will not chair. I'm happy to moderate if you allow me to do that, okay? So thank you very much. So I think these are very nice presentations which you both made. I have a few remarks before I ask the panelists online and to a few. Jean-Daniel, you made a presentation on priority setting, and there you have implementation research, social science research, basic science research. And then, Madame, you made the presentation on research funding, and it went all the way to the basic science research and the clinical research, because there was hardly any issues raised or discussed. How can we fund more social science research, more implementation research, more systems research, more policy research? And to me, that's a very natural way we drift as scientists, because most of us here, I'm just assuming now, so if I'm wrong, are basic science clinical researchers here. They're hardly in the room, maybe one or two who are the social scientists, or maybe systems researchers or policy researchers. So to me, that gives an inherent bias to all of us. And it's not like I'm not making any comment, like I think basic science researchers, clinical scientists perhaps are the most important, and they have proven during the pandemic by producing the vaccine in less than 2 years. However, the issues in the morning, in the opening remarks, the Director General of the Ministry of Health of the French government used the word 3 times sustainability, but we have not used the word systems or society. The system only came once when was the reminder systems, And then I think Sarah mentioned system very lightly. The reason I'm highlighting all these points is that vaccines production, use is important. However, we have realized that despite very serious ongoing pandemic, some sort of a hesitancy has gone up, both into the younger population, relatively older population, and that's across. If you look at the social section, it is not the people who are not educated. We have mentioned again and again migrants and the vulnerable, but there's a very stable, healthy, educated population who has put their foot down and they said, we don't want vaccines. I live in Switzerland, I don't live here, but it is an alarming number we have, the people who are reluctant to have the vaccine. Having said that now, I have questions for the panelists. One of the issues we have, how do we fund our research in health? My experience, I studied, lived in US, I've living in Europe. The funding mechanism right now for the research funding, it is based on the topic. You will find a researcher who is expert in infectious disease control and then maybe TB, maybe an HIV/AIDS. And that's the way the funding mechanisms are established in all over the world. What we want is, if we really want to improve all these things which you said since morning is, and I'm not going to pick the word, it may be transdisciplinary research, maybe multidisciplinary research, whatever we want to call it. Right now, I don't know any school of public health where there's a transdisciplinary research team and there's a transdisciplinary research funding. I don't know which agency funds in Europe. MRC, CDC is obviously disease control. The word is disease control. So the first question is there a natural bias that we drift as scientists from systems, social science, policy research towards basic science and clinical research because that's easy or there's a funding available? So that's John Daniel to you, and then I will come to Karian.
Yes, it works. Thanks a lot, Abdul, for this comment. I completely agree with you, and I think it's the relevance of this kind of prioritization. It's to highlight what are the needs for at the end, and the needs are not always to have funds for basic research, but to have this overview of what we need and the fact that we need to implement vaccine in the real life, and which is not the case. And you know, I'm basically before all a man of basic research as an immunologist, so it's quite easy for us in a way to find fundings for our research, but it's harder if you want to implement directly the vaccination in your country. I completely agree.
Thank you very much. Karian, so do you think there's a real challenge for research funding? Because the research funding systems are biased towards the basic science, clinical research side, and we miss, if we want to really look, if we have to, we all know how to communicate, but that's a communication with Lancet or the BMJ. So is there a bias towards clinical research as compared to other, even in the vaccine development?
Can you hear me?
Yep. Yes, you can.
I think this is also, we didn't ask or phrase the questions like that. We really wanted to investigate where are the funding going. And I think that what our survey also said that it's basic research and it's the early stages who gets the most funding. And particularly from a national public health institute, I think it's really important to also have funding for implementation of vaccines in new programs to do the long-term safety follow-up, but also to do the real-world evidence. Particularly, we have seen that with the COVID-19 vaccine. So maybe we could open up for Marco and Melanie to comment on that as well.
Yes, thank you very much. Marco?
Yeah, no, I think the point from Marianne is an important one, and we got a lot of learning from COVID on a lot of different areas, and I think we should cover them all. We should not leave anything out of the scope of what should be covered in terms of research and our research agenda. If I can start indeed with the post-authorization activities, this has turned out critical. And that's why, as Karam was saying before, together with the ECDC, we are trying to build up a new system that would help all the member states to collaborate together with the two European agencies in order to have an infrastructure that can run rapidly studies both on safety and effectiveness of vaccines, not only during crisis, but also on a regular basis, so that we can answer any type of research question that is still out. And honestly, there has been a point in time here during the pandemic that all this real world evidence that were coming from Israel and US were so informative and so important. And we were wondering, where are we in Europe? What is happening in Europe? Why we are behind? And one of the big hurdles here is how to make sure that the healthcare system from different member states can talk to each other. So have to have a network that is supranational, because only like this, we will have the power to conduct studies very rapidly that will give us all the information that we want really in a short period of time. So this is the ambition, and this is what we want to build together with the ECDC and the member states, because of course the member states, they have the information, the starting point, the data are in their hands. But we need to make sure that we have a system that is able to merge all this data, allow the system to talk to each other, and collect all this data on effectiveness and safety as rapidly as possible and in a very robust way. I think we can do it in Europe. So it's a matter really of putting together all the efforts and joining forces and make this happen, because this will also be the starting factor to address also hesitancy, communication on vaccines. Only hard data will be very effective in convincing people. So we need to make sure that this is happening. And then, of course, there are many other areas, and I would just quote the ability of conducting large clinical trials in Europe. That is something that also was missing. We saw that in the US, they were able to set up very rapidly the infrastructure to run phase 3 trials for COVID-19 in a matter of few weeks, while in Europe, we were really behind, and we really needed to, prepare the ground to make sure that this is happening. Now we got these new consortia coming up, like Accelerate, that have the potential to make this happening, and we should enable them to really be effective in running multinational clinical trials that will be faster and will address all the questions. Of course, the problem with phase 2, phase 3 trials is that they are tremendously expensive. And that's why also specific grants in Europe so far have not been able to cope with any of these, or at least not to cover full the cost of all of them. This is an area that we need to work on. And I believe, again, here we have the chance of building, first of all, the infrastructure, the network, the capacity of doing studies, the capacity of doing immunogenicity evaluation, the capacity of doing also laboratory work more in general with pathogens that might be BSL-3, BSL-4, and then, to see what could be the best framework for funding, whether ERA could play an important role here. Because again, and maybe my last point for the time being would be that in Europe, research has always been funded with all these very specific grants, not looking at really a portfolio approach, not looking into the broader perspective. And maybe it's time now also to think about the broader perspective, thinking not just about giving grant for small pieces of research, but trying to think where we are heading to, and try to have a more coherent and consistent way of looking into what would be the final outcome in terms of having new vaccines and convincing more people to get vaccinated.
Thank you, sir. Is Melanie online?
Yes, I am, and thank you.
Okay.
And maybe I can just add a few points to those of Marco. And I think really what the critical issue is, what is the, the long-term goal of any specific research, any particular vaccine that you're looking at, that unless you have that true long-term goal, you don't know where the research questions or when the research questions need to be specifically answered. And certainly from a CEPI perspective, for those who may not know us, so Coalition for Epidemic Preparedness Innovation, we set out 5 years ago with a goal of accelerating vaccine development for priority pathogens for emerging infectious diseases, and obviously reacted very quickly to the COVID-19 outbreak and have learned a huge amount from what our objectives were, which were really quite long-term objectives for the vaccines that we're developing and for COVID-19. And I think one of the critical pieces there is having the right partnerships in place. And COVAX is a good example of that, with CEPI managing the R&D and manufacturing side, Gavi, the procurement, WHO for allocation, and UNICEF for delivery. Quite early on in the pandemic, we had that end-to-end approach, which I think helps to focus in on what are the right research questions when you're really looking across the various organizations that see things in quite a different way. And to your point, how much social science can you introduce into the clinical research to help prepare for the introduction of a vaccine is a critical piece there. We all have our own expertise, but we need the expertise of others to make sure that we optimize the research that we're doing and that the funding comes in that regard. And I think from a funding perspective, these are often global questions, and it's about collaboration also between funders. CEPI has an example of, obviously, we have co-funded a number of projects through Horizon 2020 funding and Horizon Europe moving forward. So in that regard, I think it's about funders getting together also and utilizing the resources in the best and most efficient way possible. I really do agree with what Marco says. We should not be looking at funding small chunks of things. That is the way to move things forward very slowly. A fully integrated approach clearly is a much better approach and will accelerate the development, licensure, and introduction of vaccines. Thank you.
Thank you very much. I'm very cautious of the time, so I will make a remark and then we'll go for any questions. My only plea is, like there's a European Space Agency, they manufacture these rockets which go into the space or should go to the space. And they spend a lot of money in manufacturing those rockets, but they also manufacture in the delivery system. So I think we need to invest whatever we are doing in the basic science, clinical research, vaccines, to invest some in the delivery science so that we know how can we deliver whatever we have produced. So in the interest of time, is there any question? Otherwise, I'll come back to the panelist. Okay, I think people are really hungry. So Melanie, I have a question, because you said funding is complex and fragmented. And then you say the money, most of the governments don't invest. Do you have any idea? Why do you think governments don't invest money into the R&D?
Why most money goes into R&D?
Yeah, but not from the governments.
But I think it's very easy and tangible, because then you are actually financing a product, a vaccine, but to really financing surveillance system, to do real world evidence effectiveness, you really have to fund the sources within the countries, which is more harder. So then you need really to be able to collaborate more on funding. But I think that is really needed, because if we want to implement vaccines in the population, we need to understand vaccine hesitancy. We need to have surveillance systems, because you don't only need a vaccine, you need to track and diagnose the disease, and you also have to follow the use when you have implemented it into the population, also for risk patients and the follow-up.
Thank you very much. Jan Daniel, you have 30 seconds to close. and say whatever you want to say.
Yes. Thanks to all for this session. Just one concluding remarks. We have to keep in mind that obviously we have spoken a lot of COVID-19, but we still have important research questions on all vaccine and, for instance, on measles vaccine acceptance and so on. So don't forget also these important questions. And I close the session, and thanks to you, Abdul.
And thank you to both
the
Melanie
panelists,
and
to
Marco
Marco
also.
and Melanie.
Okay, thank you to both. Thank you very much.
So we'll go back to our next session in this EU-JAV final conference. And I will give the floor to Mr. Ryan, Director, Public Health Directorate General for Health and Food Safety from the European Commission. Thank you.
I wonder, can you hear me now? Can you give me the okay?
Yes, thank you.
Apologies. So dear European Joint Action for Vaccination, dear colleagues, I'm very happy to be able to represent the European Commission here today at the closing conference of this important joint action. We've had more than 3 years of hard work and coming to an end, and I know that all 20 partners in all the 8 work packages have been working very tirelessly since the 1st of August 2018 to submit the last deliverables, which are due, I understand, by the 31st of March of this year, the official end date of this joint action. And we look forward, of course, to seeing all these deliverables on your website. Today, I'd like to pay gratitude to all the partners and all the work package leaders for their commitment to carrying this joint action through, despite all the challenges posed by COVID, the health crisis of a century, if I might call it that. I'd also like to thank all the involved collaborating stakeholders. Your joint action, of course, is not the only joint action to face challenges from COVID-19, but your joint action is a joint action on vaccination, and this means that many of your partners have also been heavily involved in national efforts to make sure that as many European citizens as possible got vaccinated against COVID as fast as possible once the vaccines became available. Still, you've carried through this joint action, kept it afloat even in difficult times, and I'm very grateful for that. The vertical work packages of this joint action, work packages 5 to 8, have been looking into how we can use an information system for immunization to strengthen the surveillance of vaccination coverage rates across Europe. In work package 5, in work package 6, you were looking at how we can work together to strengthen vaccine supply and preparedness, as well as vaccine research and development in work package 7, and how we can increase vaccine acceptance in work package 8. The horizontal work packages 1 to 4 have been making equally important efforts in terms of coordination, dissemination, evaluation, and integration of the outcomes into national policies. It's also time to make sure that all the good things you have done are now taken up, integrated, and sustained in national policies. There are currently signs that we, at least here in Europe, are transiting into what we could call a post-acute phase of the COVID pandemic. While this will require us to stay vigilant and constantly assess the need for further rollout of new or existing COVID vaccines, including booster doses, it will also allow us to focus again on the importance of vaccination in general, and not only vaccination for COVID. At the same time, COVID has highlighted the importance of vaccination as such.
And this gives us a window of opportunity to draw attention to all the other life-saving vaccines at our disposal. Thinking here in particular of HPV in the framework of our EU cancer plan. As you all know, the Commission's work on vaccination in general is based on a Council of Ministers recommendation from 2018. That particular instrument followed on from major measles outbreaks around the same time. There's a roadmap set out in that Council recommendation, and your joint action really feeds in very well into that roadmap. For example, you have helped us to identify barriers to access and to support interventions to increase access to vaccination for disadvantaged and socially excluded groups. You have also developed EU guidance for establishing comprehensive electronic immunization information systems for effective monitoring of immunization programs. Thirdly, you have developed evidence-based tools and guidance in order to support countries to anticipate, to preempt, or to respond to crisis situations. You've also been developing a virtual European data warehouse on vaccine needs. And finally, you've been looking for consensus on unmet population needs and agreed priorities for vaccines that can be used to inform future vaccine research and their funding of this research at national and EU level. All of these things were things we were supposed to do in the text of the Council of Ministers recommendation. So you can see that from the ministerial level at the EU Ministers of Health into what you produced in your joint action, there's a great link between these two initiatives. According to the timeline of our roadmap for implementing this Council of Ministers recommendation, all the actions are supposed to be delivered by the end of 2022. And this means that the Commission, at the end of this year, will have at its disposal a full inventory of actions on which it can base its future work on vaccination in general. I'd like to talk now about the EU for Health programme, which is one of our financial instruments, which is available to us over a 7-year period from 2021 onwards. The EU for Health programme includes an initiative which we call the EU Immunisation Initiative, which we're launching at the moment and which will have the overall goal of increasing vaccination coverage rates, taking the lessons learned from COVID into account. The uptake, the integration and the sustainability of the outcomes of what you've been doing in your joint action, international policies, will also be included as part of this funding instrument. So we'll be trying to reach out to the member states and to our partners in order to channel the available funds into supporting the outcomes and sustainable outcomes of your joint action. I hope that the partners who've been involved in the joint action will also accompany us in the next stages of this process, particularly I would say in respect of Work Package 4, which is concerned with sustainability. And I know that you will have a dedicated discussion on this later this afternoon, including on your sustainability plan. I hope that this discussion will be successful so that the member states and citizens can, in the near future, benefit from all the good things that you've been doing in the joint action. As I mentioned at the beginning of my intervention, there could be no better timing. The COVID pandemic has given us a window of opportunity to promote vaccination. And I hope that we can together use this opportunity to the best of our ability. Thank you very much again, and I wish you success for the remainder of the conference.
Thank you, Mr. Ryan. I don't expect us to have any questions or comment on this intervention, but thank you very much for your support and these remarks and this recommendation concerning the near future of the EU-JAV or the post-EU-JAV period. Thank you very much. And now we will welcome the team who have worked on vaccine hesitancy, both the best practices to address this problem and the monitoring on the social media. And so I am calling Jonas Sivela from Finland and Francesco Gesualdo from Italy.
Great. Are the mics on the right level? Can you hear me well? Perfect. Hi, you met me previously. I'm Jonas Sivela from the Finnish Public Health Agency. Me and Francesco Gesualdo will walk you through work package 8 on vaccine hesitancy and uptake. It's been done in a collaboration between us, THL, and the Italian team. On a general level, it is divided into two quite different parts. The first part, which we at DHL were leading and are leading at the moment still, deals with increasing understanding of vaccine hesitancy and uptake and creating tools to tackle issues relating to vaccine hesitancy and uptake. And then the Italian team has been working on understanding and monitoring social media sentiments and opinions through a different tool, and Francesco will tell you about that after my presentation. So the first part, from research and practices to implementation. This part of the work too can be divided into two different sections. The first one has to do with increasing the knowledge base, and the second one with disseminating this knowledge. So we started out with creating a tool for mapping the situation or the understanding of vaccine hesitancy and uptake and the work related to it. And the tool, which many of you, I think, were forced to work with, Majid and Sarah at least, and many others, was a quite heavy tool with quite a few questions, and many of them open-ended questions, which required quite a lot of work from you. This survey tool was sent to the institutions or the actors responsible or with the best knowledge of the national immunization programs and activities within these programs. And this, of course, was also a big effort to try to identify the right actors in the field. And later on, we modified this survey a bit and sent it out to stakeholders. We did the data gathering between November 2019 and June 2020 for the countries, and this was also challengingly enough the time when the pandemic started. But even though we got a very heavy crisis in the winter and spring of 2020, 28 out of 32 countries who were asked to respond did so, and this is, I think, one of a huge success too when it comes to the data gathering. We looked at different issues, and if you look at the main topics, we wanted to understand how the different countries and the stakeholders too, what they mean when they talk about vaccine hesitancy, how it is understood by the different actors. Also, how they perceive the situation. if there are differences between the different countries in how they perceive the situation when it comes to vaccine hesitancy and confidence and uptake in general, and also examining what has been done and is done research-wise in connection to this. And also, maybe most importantly, what is and has been done to improve things, to strengthen confidence and strengthen uptake, and how we are organized when we do this, how the different countries have organized their work, and how the different stakeholders have organized their work in the field. So we have, of course, a lot of results, and these results are published in a final report, and the link will be here later on, and feel free to take part of that. Just a couple of highlights from the results. So when we looked at the concept or the definition of vaccine hesitance and how it is interpreted, we saw that it is interpreted in very many different ways in the different countries. And this is, of course, something that might also make the discussion difficult between the different actors if we if we have a different understanding of what we are talking about. Vaccine confidence, however, was something that was emphasized quite a lot among the different countries and in the different countries and stakeholders. And this is, of course, interesting because we know that vaccine uptake is affected by many different questions. And for example, it can be organized or looked upon in different ways. One of the definitions is based on a WHO understanding or definition of the topic, where we look at where we understand vaccine hesitancy to be constructed of issues related to confidence, complacency, and convenience. We use this as a background to examine the questions, and saw that yes, countries do understand and see it in a similar way, but there was very heavy sort of emphasis towards confidence being the most important thing or issue affecting vaccine hesitancy and uptake. This is a thing that I think the part looking at how the vaccine hesitancy and uptake work is organized is something that I think interests quite a few working in the field, and we approached this in different ways. But I think the alarming thing here is that most of the countries do not think that they are able to work with these issues in a way that meets their needs, and this is, of course, a very concerning thing. We made some conclusions based on the work done, and as I said, they are published in the final report, and it is quite thick. So you will find more detailed elaborations there. But if we would like to, or we want to conclude something from this, from the results, and maybe highlight some topics and even recommendations, we need, as I said, a more coherent way of defining vaccine hesitancy so that we actually understand all what we are talking about. We also need to have a more holistic approach to the topic right now. And so far, very much focus has been put on vaccine confidence. Here, I'm very happy to see that the Commission has put out a tender act on approaching the uptake matter from more practical, from the more practical side, focusing on also other things than confidence. We need still to be better at targeting different population groups. There is still a lot of overlap, so we can, with more coordination and better coordination of collaboration, we can do the work more efficiently. And one very important thing is that we need to start to appreciate this kind of work. It is still, as someone said previously also during the meeting, is something that is quite often done on the side by some social scientists. It doesn't yet have the appreciation it should have. And COVID at the latest has shown us that we also need to understand the human perspective and the human being who takes the vaccine in order to ensure that the uptake is good enough. So the second part of the work, we also wanted to disseminate the knowledge we have just shared. And in order to do this, we launched the Vaccine Hesitancy and Uptake Network on the existing EU health policy platform in order to support the countries, in order to support the actors in the field. And so far, the contents on this platform is based on our work in work package 8. It provides the network. It includes descriptions and presentations of good practices. For example, studies, campaigns, publications, different activities done in the field. It also includes all the results from the big data gathering. So it includes reports from all countries and in many cases, very detailed descriptions of what has been done. So far, it has more than 60 publications, and we are hoping to increase the number, of course, in the future for this. And we are able to organize webinars, which we did a couple of weeks back. Together with the coordinator and the Italian team, we presented results from this work, and it has other practical functions too. For example, if you would be interested in looking up campaigns or work done related to HPV, you could use keywords to find the right information. These are just some examples of what kind of contents we have, descriptions we have. Just to show the variety of it, there is about the first one is about communication campaign and work in Ireland. The second one is the WHO TIP program that was already mentioned by Sarah, which is a valuable tool if you want to work with, for example, with specific population groups in the society, descriptions of campaigns and of studies. And also we have quite a few descriptions of COVID-related work that has been done in the field. This is what it looks like. This is all for me. I will hand over to Francesca.
Thank you. Thank you, Jonas. Okay, so I'll try to condense in the presentation an explanation of the methodologies and of some of the results and the inspirations that we got from developing the social media monitoring platform for Work Package 8. So these were the objectives of the platform. So detection of early signals of lowering public confidence and selection of the most influential players, but we went beyond it, trying to also develop additional functions that we thought could be useful for giving a quantitative and qualitative idea of vaccine confidence and hesitancy on social media. This is a list of the main methodology points that we went through. First of all, we benchmarked the available solution, and I decided to put the date on that point because it was 2008. Meanwhile, lots of things that have changed, both in the scenario of vaccinations in Europe, but also especially from the available solutions that are present on the market. So this is an important point because we should always keep an eye on commercial or available solutions that can be sort of customized to the needs of public health. We selected 4 data sources to be investigated. Why I must stress here that one of the main purpose of the main character that we wanted to give to our platform was transparency of methods, which is what probably distinguished it from available tools, because often in commercial tools the methods are not really transparent and clear, while we wanted everything to be transparent and traceable. So we selected these 4 data sources. We created vaccine-related keyword filters based on a structured framework. We cleaned the data in reiterated processes. We created an event detection system and a system for analyzing the community that was involved in the vaccination discourse on social media, and a system that allowed us to detect the influencers, both on the pro-vax, on the favorable to vaccine community, and in the hesitant and no-vax community. Maybe this coming to the end of these years of work, we developed probably what's the most refined function of the platform, which is based on artificial intelligence and machine learning. What we decided to do is to create, very much inspired by the work done by Heidi Larsson's group for the Vaccine Confidence Project, we decided to train an algorithm to detect automatically the stance of vaccine-related tweets in Italian, as a sort of pilot that could be replicated in other language of the European Union. So this is an example of 4 tweets that could be classified based on their stance as promotional, neutral, discouraging, and ambiguous, and which is a kind of classification that works much better in terms of machine learning to classify tweets, rather much better compared to sentiment analysis, which is something that is a bit controversial when used with regards to vaccines. Just a very quick overview of the platform functions, especially to leave as much space as possible to the discussion later on with the panel. So this is the first page, the homepage of the platform. What you can see here, these 3, Italy, France, and Spain, were the countries that were included in this sort of pilot, the first step for the platform. Then we have the possibility to select a time frame, and the main source of information was Twitter. That was explored was Twitter, and this trend shows the daily volume of vaccine-related tweets based on the validated keyword filters that I said before. Then we have a section that is showing the most the users that tweeted most, the users that posted the highest volume of retweets. I'll go through this later on a bit more in detail. Here we have the event detection system with the counting on the hashtags included in the tweets. That is one of the most useful and recognized as reliable methods to see when a specific topic is gaining attention on social media and on Twitter in particular. It was very interesting to do the pilot in these 3 languages. In this, actually, we developed also a geolocalization algorithm for the posts, so it was really not only the languages, of course, but also very specific to the countries, and it was interesting to see the comparisons. Please note that this, due to some, software constraints, the 3 graphs here do not have the same scale. So actually France is the country where the most of the tweets were published. But anyway, the trend of the tweets was interesting to be compared across the different countries. And this is back to the players of the vaccination discourse. This was based on recognized algorithms to identify who are the most influential players in the discourse with specific metrics that are normally used by brands or companies to identify, for example, who is speaking more or could be more useful to promote a specific product. In this case, it was very useful to keep an eye on who are the most influential players from the pro-vax community, from those that are favorable to vaccines, because those nodes can be useful, for example, to spread science-based facts and recommendations. And also, it was useful to keep an eye on those nodes that were very, very active in spreading misinformation and disinformation around vaccines. It was keeping an eye on those accounts allowed us to timely detect the diffusion of specific misinformation. We also included, we connected to the Google Trends API that shows the volume of searches on Google on the vaccine topic, and the related queries that are used by Google search users. Giving us information on what specific arguments and topics are searched related to vaccines. Along the way, it was clear that this quantitative information was very, very useful and actionable, but probably was not enough. So what we did was we decided to explore qualitatively, together with the help of some social scientists from a couple of Roman universities, and we studied a very large volume of vaccine-related tweets and characterize them from many points of views. I'm going to present here just the dimension of vaccine stance that we detected from this random sample of tweets. And as you can see, and it's again specific to Italy, from November 2019 to June 2020, as you can see at the beginning, it was a random sample, but probably it was quite a reliable randomization, and it's interesting to see how the red stance, which means the discouraging stance towards vaccine, was really strikingly dominating the conversation before the pandemic, at least on Twitter in Italy. And then the promotional community, the users that promoted vaccine, the favorable look on vaccines, good vaccine confidence, just started to talk a lot more, probably, and this was triggered by the pandemic. At the beginning, the discouraging tweets sort of shrinked a lot, and this is described as by social scientists like the spiral of silence effect, because the theme at that point was very controversial. It was just the beginning. They were starting to talk about vaccines, but COVID-19 vaccines, everybody silenced from the no-vax community, and then they gained again quite a bit of space in the discourse. But the good effect was that people talking in a favorable way towards vaccine were present anyway. And then getting to the end of the presentation, I wanted to tell you quickly about this function, which is based on the machine learning training, the training of a machine learning algorithm for automatic stance detection. So the work that we did on the 3,000 randomly selected tweets qualitatively took a lot of time and lots of energy, and also in order to do it in a reliable way, you have to have multiple researcher classifying each tweet. It's very time consuming and energy consuming. We decided to see what happened if we trained an algorithm that did it for us. And as I said, we were inspired by work done by the Vaccine Confidence Project in maternal vaccination. We used the same classification of stance, which we thought was very, very useful and reliable, and we trained the algorithm. This is an interesting result that we found. So this is a confusion matrix. The darker blue square squares are those in the diagonal. It means that the predicted label, as we just focused on promotional, neutral, and discouraging, the predicted was the same of the true label that classified by the researchers. So the darker the squares in the diagonal, the better performing is the algorithm. So we trained the algorithm on those tweets that were that had been published between November 2019 and June 2020, and we got an accuracy of 73%. Means that 73% of tweets are classified correctly, and this for a machine learning algorithm is a very, very high number from what our data scientists told us. And what we did then is that we noticed that the language and the tone and the contents and topics of the tweets when the vaccine was rolled out had completely changed from what happened before. So we said, okay, what's going to happen if we apply the algorithm to most recent tweets? And actually the accuracy dropped quite dramatically. So this told us that an algorithm is not a static, product that you achieve from training, but you have to retrain it periodically, probably every 6 months is a reasonable time to address changes in the language. And in fact, we retrained it and we went up to a reasonable and acceptable accuracy. And this is the function included in the platform. So we added this section that shows, based on the algorithm predictions, a weekly proportion of promotional, neutral, and discouraging tweets. These are the recommendations and the lessons learned by this experience of making the platform. So first of all, constantly monitor available online products from social media monitoring. Probably a long time more transparent and more powerful tools will be available online, should be taken into account for social media monitoring at the public health level. Keyword filters are very important to detect consistent tweets, consistent posts, and this should be an effort should be put in the creation of validated keyword filters, and also in this case keyword filters should be updated over time. Quantitative data are very useful, but qualitative analysis is very useful and needed to dive more into contents. Event detection system can help spotting the emergence of critical communication issues, but it's important not to forget that it's been confirmed by many studies that debunking single misinformation and disinformation pieces is useful, but it's very important to do the inoculation of science-based understanding of science-based facts, and to teach people to understand science-based fact in order to get a long-term results. Monitoring influencers can be very useful, as I said before, both identifying nodes with vaccine confident nodes and vaccine hesitant and no-vax nodes. And the algorithm for stance analysis is mandatory to analyze different high volumes of tweets. Keep in mind that we can virtually train the algorithm on any kind of classification. So I was very interested in having a conversation with Sarah before on a study that has classified tweets based on the 5 C's of the 5C model for vaccine hesitancy, for example. We could train an algorithm on that, and that could be very, very useful. This is ideas that are generated by in-person meetings again. And finally, another very important thing that we understood is that vaccine confidence is very context specific. So we should keep into account that probably it's great to have this double look. So have a comprehensive look at what happens in Europe and then focus freely on specific characteristics in specific contexts. And that's all our contexts. Okay, thank you. Okay, we're good with the time.
Now we have the panel. I hope that the panel participants are here. Are we able to check that? We have Sanjin Musa at least here in person. Please, would you like to come to the stage? And then virtually we should have Sif Nielsen from WHO. I hope. Are you able to see if she's here? And John Kinsman from ECDC.
I am here.
Hi, Sif. Welcome. Can you hear us?
I can hear you clearly, and I can see you as well.
Great. Thanks a lot. And then John, are you here?
I am here. Can you see me and hear me?
Yeah, we can. Great.
Okay. And I should apologize. I've got the wrong background, but that's from a previous meeting. Sorry about that.
No worries. we see your message clearly. And then we should have George Panagiotakopoulos from Greece.
Hello from Athens.
Hello, welcome. I think we're all set, or according to my list, Karam wasn't able to join this panel as planned, unfortunately. So in the same way as we did the presentation, we thought that we would split this discussion into two parts. First, looking at maybe the more general questions relating to vaccine hesitancy work and the topic in general, and then from there move on to the social media part. Just a question to the virtual panelists: are you able to see the screen with the questions?
So I don't see any questions.
You don't see the presentation?
No, I see a blue screen, but no words on it. But maybe it's just my screen. Let's see if
me
the
too.
others.
I don't see it either.
Okay.
Are you able, John, to see anything?
No, I see you and
You see
someone
me.
sitting down and then me.
Are we able to do something technical about this, maybe? To see the presentation, to show the presentation to the panelists.
Okay.
That would be
There we go.
great.
Yeah, I can see it now.
Yeah.
Oh, great.
Now not.
Wonderful. Thank you
There we
so
go.
much.
Mhm.
Great. So we will not go through all the questions in specific, but looking at the three first questions, what do you think should be the focus areas of vaccine hesitancy and uptake work in the future? How could we better coordinate and capitalize on the existing work? And how could we better prioritize vaccine hesitancy and uptake work? Thinking about these three questions in the beginning, it would be interesting to hear your thoughts and your comments on these. I was thinking maybe we could start with Sanjin, as you are here in person, and then move on to Sif, and then John,
Okay.
and then to George.
If I just can give one suggestion, maybe you can join also here, you know? So,
Sure.
Yeah,
Yeah.
let's make also
Absolutely.
here more. People who are in person here, so, yeah. So thank you, Jonas. So I was thinking really at the end now we have vaccine hesitancy, but of course everything is interconnected, you know. So whole today conversation that we have, you know, discussions that we have could be linked with also with vaccine hesitancy. Today someone mentioned also that you have also supply issue regarding that. For me, from my perspective, someone who is coming is from LMIC. That is also important factor, you know. So also one, I would say, I would like to underline important question and findings from, I do not recall which package is that, but with vaccine shortages. I was so surprised when I saw that results. I also give my answers for that, you know, and that so many countries in EU in EU are experiencing vaccine shortages, So, but that's not the end of the world, So it's temporary shortages, you have to recall system that is also one of the key factors for vaccine hesitancy. Is important, but so that also it obviously in some countries can be one issue. Regarding the vaccine hesitancy in Bosnia and Herzegovina in Federation, we did a lot in recent years, mainly because we implemented the TIP project supported by WHO. So we started that 3 or 4 years ago, 2 years before the pandemic, and we really acquired a lot of knowledge regarding all these insights regarding the barriers and drivers for vaccination. So we started with work with healthcare workers, then with the parents who refuse vaccination. So based on that, this final TIP report you can find on WHO Euro website. So it's really published like 2-3 weeks ago with fully how we implemented it, designed it. And at the end, we have created interventions. So 2 interventions before pandemic we implemented. Unfortunately, we have ideas for further one, but 2, I would say, which are, I would underline as maybe even the most important, are related to communication of healthcare workers. So yeah, so all that paradigm and communication between parents and healthcare workers, this is also from our findings from qualitative study, raised that issue that, yeah, now it's difficult and the parents challenge now physicians regarding some questions in connected with vaccines. So they have to be knowledge, to raise the knowledge also, but also some things that we implemented by support with UNICEF. One program, I think Hill is also colleague from Serbia, that they also implemented it. It's so-called interpersonal communication on immunization. It's one program developed by Johns Hopkins University, and we implemented that in Bosnia and Serbia. And I was also a member of UNICEF team who implemented that in Icaro region. So this is also something new. I would say that is important. That for vaccines, it's not just that you have to provide information, So you have also to use empathy and other non-verbal, verbal techniques, how to convince someone, that is important. So vaccine hesitancy issue is really important. That also show us pandemic. So the first challenge was how to develop safe and effective vaccines, and that was excellent job. Then how to produce and distribute vaccines. I would say that was far from excellent, right? From my perspective of my country, and other countries, LMICs. And the third one, how to convince people to get vaccinated. That also, some countries did do good job, some countries didn't do good job. Also, all during pandemic, we also, by support of WHO, we implemented one behavioral research, and one of the questions was regarding to vaccination. And that will be very soon published in International Journal of Public Health. And for me as a researcher, that was really interesting we ask about vaccine intentions for vaccine that are in developing process. So that's also interesting. Thank you.
Thanks a lot, Sanjin. Just to check, Sif and John and George, can you hear me when I speak to this microphone?
Yes, we can.
Great. Sif, would you like to take it from here? It would be great to hear your comments and thoughts.
Yes, I can do that. Okay, thank you so much. And thank you so much for the invite, and good afternoon, everyone. So I think what I would like to share in regard to the vaccine hesitancy is that somehow I think the last year dealing with COVID-19 uptake in various countries in the European region, I think that's a good example of somehow we should try to be a bit more nuanced when we talk about vaccine hesitancy. And what do I mean about that? I think somehow we should try to talk about vaccination readiness, because when we say vaccine hesitancy, we indicate that people are not keen on getting the vaccine. And the studies that we have done in more than 10 countries over the last year on COVID-19 vaccination actually show something different. So, and it shows a more nuanced photo and a picture of it, and also a more, as mentioned in the presentation, a more holistic approach to it. So actually what we have seen is that not necessarily are people hesitant to get the vaccine. There could be structural barriers. and even more important, actually often programmatic errors or issues. And what do I mean about that? So that's really trying to look at the entire national immunization program. And that's what I meant about the holistic approach. Because often when we talk about vaccine hesitancy, we somehow put the blame on the population. So it's easier to say that, it's the reason that we do not see a higher uptake is due to vaccine hesitancy. People, they don't want to get it. It's misinformation circulating on social media. And we then put the responsibility on a population level, and we forget about what else can be done from a more programmatic level, but also politically. It has a great influence. And for instance, with the COVID-19 vaccine, we have seen results where, people are keen on getting, any other vaccinations, but the COVID vaccine were the one that they have been a bit hesitant in getting. And that actually shows that it's nothing to do necessarily with the vaccine. So it's not the vaccine that they're against. There could be any other issues, the way it's been communicated about in the country, the fact that, the government might not be visually supportive of the COVID-19 vaccine as well. That could be, communicating about the COVID-19 vaccine from various stakeholders, not being aligned, not having one message. And of course, also the fact that there's, a lot of negative influence from social media. So it's not that I want to disregard that for sure. However, our result has actually shown, so we have worked with more than 10 countries to conduct qualitative research to understand the barriers and drivers for COVID-19 vaccines among specific target groups. And based on that insight, we have supported countries with conducted tailored interventions. So we have tried to look at anything that can have an influence on the willingness to get the COVID-19 vaccine, of course, personal knowledge, social factors, but also programmatic issues. As also mentioned, that could be the convenience factor, that could be, lack of stock supply, not feeling comfortable to go to the healthcare facility and so on. So really also look at the programmatic issue. And actually, when we look at the recommendation that we gave to the countries of interventions, like more than half or 50%, in some cases, even more than that, has to do with the actual, structural programmatic issues. So not necessarily, trying to tackle misinformation on social media or big communication campaigns that are targeting the general population, but actually much more narrow on either really deep in on community engagement and or programmatic issues. So I think it's important when moving forward that trying to maybe approach the vaccine hesitancy a bit differently, maybe talk about it as vaccination hesitancy or readiness. So we also somehow try to, have a positive discourse about this, because people that are actually keen on getting the vaccine, but the more that we try to emphasize the vaccine hesitant part, somehow there's a bit of a negative and a bit of resistance to it. I hope that makes sense. And then, of course, moving forward, working together, how can we coordinate, align? I also think that each of us should be better at, documenting what we have learned. The information that's already out there, it's actually a bit limited in regards to which interventions is actually working. We have an idea of now the barriers and the drivers, but when talking about implementation, action, what works, it's actually quite limited what's out there. We know at the broad sense, education, training, but again, it's super context specific. And it would be great to have a bit more documentation of what is actually meant by training. What kind of training, the content of training, what is the trigger part? When we talk about communication or community engagement, what's actually meant by that? So a bit more specific, concrete example. I think that would be great to be able to share, among other countries, because I think that gives a bit more concrete, a deep understanding, insights into what can actually be done to make a behavior change among different tailored target groups. I think that was it from my end, and I'm happy to elaborate over.
Thanks a lot, Sif. I couldn't agree more with what you just said. Many things that are really topical and important. John, would you like to continue?
I would, and I would also just like to say that what Sif has just said is, to some extent, exactly what I was going to say, specifically referring to the concept of vaccine hesitancy, which I think is a somewhat overused and often ill-defined term. And with it comes a lot of values. I think it's very easy to judge people for being so-called vaccine hesitant. And in fact, what they really are is unable to get someone to take care of their kids so they can actually get to the place to be vaccinated. And it's a structural issue. And essentially, if I may say so, it's actually a failure of the state to provide a service, an essential service for the people on the terms and an acceptable way for them. So I think and this is something at ECDC that we're really trying to move away from, is to not use the term vaccine hesitant. Not that vaccine hesitancy doesn't exist, because it does, but because the term is often ill-used, and I think therefore it's a risky term to use. We tend to talk about vaccine acceptance, exactly as Sif says, spinning it in the other direction, trying to see it in another light, so that the normative behavior is to accept, rather than the implicit behavior that is normative to be hesitant. So that's one thing, and very much to endorse what you've said there, Sif. I'm aware of time, so I'm going to be very brief. Two other things I want to say. There's much more I would like to say, but there's very shortage of time. One of the challenges I think we have in this field is something of an overabundance of models and frameworks, and we don't really have an approach to using these. And somebody mentioned earlier the 5 C's, which I personally agree. I think it's a really useful, very simple model to use. You could also talk about the 3 C's, the 5 A's, the BESD model, and all these different things. But I think the fact that we've got these different models essentially saying the same thing in different packaging is problematic. And I think moving forward, it'd be really helpful if we could have a discussion about how we could somehow consolidate this sort of plethora of different models into something which would be a bit more easy to grasp for people. Final point about prioritization. It's amazing to me how 6 weeks ago, everything was all about Omicron. Everything was all about, we desperately need to get people vaccinated. This is the issue. In the current climate, vaccination has completely fallen off the political prioritization. And this is very problematic because obviously COVID hasn't gone away. We're also very potentially facing a serious upsurge in measles cases anytime soon. We can expect that to come because of under-vaccination of kids during the pandemic. So we have to be very, very careful about how we prioritize this. We need to strike while the iron is hot whenever the opportunity comes. And so just finally, just to say, if we are unlucky enough to have an upsurge in vaccine preventable diseases such as measles in the coming weeks and or months, let's take the opportunity as position, hopefully who can be listened to whisper carefully in the ears of the decision makers. Let's now focus again on vaccination. Let's not lose this train that we've been on so effectively with COVID. So when there's an opportunity, we must strike, and we mustn't let our attention be completely absorbed by other horrible things that are going on in the world. So let's just keep the opportunity going for whenever it comes. Thanks very much. I must stop there, otherwise our other colleague won't have a chance to have his word. Over.
Thanks a lot, John. I really appreciate it. George, are you still here with us?
I'm with you, still here.
Great, thank you. It would be really great to hear your thoughts about all this. Please go ahead.
Good afternoon from Athens, Greece. Thank you so much for participating in this very interesting meeting. I really enjoyed the presentations. They were very to the point, and they contained a lot of information. I more or less agree with the previous panelists, so I will be very short in my intervention, just a couple of points. Let's discriminate hesitancy from anti-vaccinationism. It's a different term, I would say. It's milder. Hesitancy is debatable somehow. It's concern. We have concerns. Concerns about what? I should like to split in two: concerns and hesitancy about efficacy, concerns and hesitancy about safety of vaccines, because it's not the same. As far as safety is concerned, I would like to stress out the pharmacovigilance field. We have pharmacovigilance in every country. We have committees, we have panels, we have organizations which are dealing with the pharmacovigilance of vaccines. So we need information from them. We need to have their data, simplified of course, and illustrated, but in a way given to the layman, so that the general public, the lay people, can be convinced, can understand that we are here to protect them. I mean, to protect them with the vaccines, that there is concern in us as well about the vaccines. So I think that if we speak the truth, of course, in an illustrated and simplified way to the general public and persuade them, we have more chances with hesitancy. This is in terms with regard to safety. With regard to efficacy, again, we need to speak the truth and have lists and have tables and have data given to the public. How many lives were saved? Out of how many? What happened with the X vaccine? Smallpox was eradicated. Let's create a story about that. And since I'm referring to stories, I also believe that we need narratives and we need heroes as well. I will give you an example. Maurice Hilleman was the cardinal vaccinologist of the 20th century. He constructed, I think, 14 out of the 20-something vaccines that we are using today. 14 vaccines were invented and devised by Maurice Hilleman. When he died in 2005, the Time magazine had him as a cover story. And under his figure, it was this phrase, Maurice Hilleman, the unsung vaccinologist, the unsung. Nobody knew him. We don't know him now either. And he was a hero of the 20th century. We don't have a movie on his life. We don't have a story. Not only Maurice Hilleman, this is an example. Jonas Salk, for example, or Alfred Sapir, or even Edward Jenner in the 18th century, who was the pioneer of vaccines. We don't have narrations and stories and movies about them. If we had, this could infiltrate society and transfer the meaning of vaccination that some serious people, some important people did, performed, and gave those things, those presents to humanity that saved so many lives, I'm strongly fond of these stories, and I believe that from a communication point of view, since we are talking about communication now, we need heroes and we need narratives. Thank you so much.
Thanks a lot, George. I couldn't agree more. That was a good narrative too, I think, from your side. Unfortunately, I think we are going over time a bit. We have time. Are you sure? Because we still have some points on the social media part. So if you have the possibility, if the panelists still can stay with us for 5 or 10 minutes, it would be great. If not, we completely understand it. And thank you a lot already for your input. But if we have the time, Olivier, we will be very happy to continue with the social media part. Francesco, I will give it to you.
Yeah, that would be great if the panelists, in fact, still have time to stay with us. We had proposed a couple of questions also on social media. One was on the idea of having a European coordination of social media monitoring, which could be, for example, for suggesting a methodology, a robust methodology to set up social media monitoring activities in different countries. And also, if any one of you has suggestions or experiences to say, probably maybe John Kinsman can give a contribution on that, on how to use data from social media monitoring to develop specific communication initiatives. If okay,
Yeah, okay, here. Thank you.
Yeah.
I'll just give you just briefly a comment. So I think it's really important. You presented us also today, and I congratulate you on your work, especially because today during the lunch we were speaking about our new studies regarding the immune response, and you have time also to do social network monitoring. But that is beauty of vaccinology. It's not just infectious disease, microbiology. That is also social sciences and how people react on vaccines. So I think that's really important, especially about these nuance, I would say. So when we say hesitant, I also agree. We shouldn't blame someone, because being hesitant, but we should distinguish here that they are not anti-vaxxers. We don't think that they are, So those who are hesitant, they are victim of propaganda. They do not spread propaganda, anti-vax propaganda. So. Yeah, they are affected, and if you are monitoring, you will see that those comments, those misinformation, etc. So I think one organized approach how to monitor it should be really important. Also, something from our region who share the same or almost the same language, that could also be important. We are releasing the same media, etc. And I found I read some analysis in a region of Southeast Europe, and really important monitoring. So, and your work is contributing to that a lot. Thanks.
Thank you very much. Any other comment from the other panelists?
Well, you specified my name, so I can try something here.
Yeah.
It's interesting you ask about the examples of social media monitoring. I mean, from an ECDC point of view, we don't do that. And there is monitoring going on in the Commission, and that they produce quite regular updates on different things that are going on, and I think probably WHO also does similar sorts of work. But I do want to give one example of a good practice, and I hope and believe it's okay to do this, which is RIVM in the Netherlands, which has a very, very good dedicated team of people working on social media monitoring. And this isn't only to do with vaccination, it's to do with many different health issues. And I'm not going to step too far into it because I'm not with RIVM and I don't want to be speaking on their behalf. But I do know that they have a dedicated team, as I say. They keep a pretty close eye on many different things. And one of the misinformation issues and things that are coming up, and I can share one thing which we have published about, so it's in the open and it should be okay to say this. This relates to Lyme disease. We did a project a few years ago on community engagement with Lyme disease, and RIVM has, of course, as many countries, there are problems where there is Lyme disease, people who have chronic sequelae from the initial infection, and this has been quite problematic in various respects. So RIVM have been engaged previously, at least, with some of the people who have been opposed to different positions and so on. And they've actually reached out to individuals on an individual basis. They've identified people online who have been saying things that maybe aren't in line with current scientific thinking, let's just say. And what's really interesting is that these people haven't been doing this to disseminate disinformation. In other words, they've not been doing it to confuse. They've been doing it because they believe this was the right thing. And by reaching out to them and by listening, I think that's the key. It's the dialogue. The social media monitoring listens to what's out there, but then the recipients in the RIVM have been listening to the people, and they have been then speaking with and dialoguing. What's going on? Why are you thinking this? And there have been cases where they've actually then been able to work with people who have then become ambassadors for a different approach, let's say. So by using the social media monitoring to identify people who may be inadvertently putting out information which isn't correct, and actually working with those on an individual basis, it's possible to do quite good things. So in terms of numbers and so on, I can't give you any details, but I do know this has happened, and I think it's been quite an effective way. So obviously labor intensive, it takes work, it takes investment and resources, but it can be done.
Very much. Thanks, John. Yeah, I think it's very interesting also to collect, probably maybe a research line for the future, to collect best practices on the way you can apply social media monitoring data. This is something that could make them very actionable and give good examples to different member states. Is there any other comments from the panelists? I think we're quite done with time.
Maybe if you have Sif or George, do you have any comments still on the social media part?
Okay, maybe.
Or maybe
we can close the session.
Maybe you have left. Anyway, thanks a lot to all the panelists. It's clearly a topic that people have a lot to say about, which I'm very happy about personally. It has been a really good and fruitful conversation together with you. So we appreciate it a lot, your participation in this. And I think we're done with this part of the presentation. So thank you.
Thanks everybody. Thank you very much.
Dear all, we will resume. And now we will have the team focused on communication and an evaluation of need for training and the training. And so I welcome Magid Derrida from France, Greet Hendricks from Belgium, and Ginevra Papi from the European Council Leagues.
Thank you, Olivier. Good morning, everybody. So Ginevra and Greet will be online. So just briefly to say you that we will present 2 pilot activities in this session that aim at exploring the feasibility of joint undertaking on vaccine-related issue. The first presentation relates to healthcare professional training, a major topic that we have already discussed this morning, and it will be presented by Greet from the University of Antwerp. I will, in the second part, Ginevra Papi from the Association of European Council League will give you a presentation on communication toward young people. So I will give the floor for the first presentation to Greet, if Greet is with us. Good afternoon, Greet.
I am so, I don't know if you hear me.
Yeah, perfectly.
Yeah,
so
okay.
I give you the floor. Thank you, Greet.
Can I see the slides, or how do you?
We're going to wait a bit now.
Okay, so since I represent the University of Antwerp, I first want to thank you, or at least the EU-JAV, to be part of the EU-JAV, because as an academic institute, it was not that straightforward to be part, but we, together with a Flemish agency, we succeed to be part of the EU-JAV, and we learned a lot in the work that we did. So what our task was in work package 4 was to look for educational activities. So we created, or our aim was to create a curricula for medical and paramedical, for students and in-service healthcare workers on vaccine and vaccination. So if I can have the next slide. Our task was divided into 4 parts. So we first assessed if there was really a need for training in service and in pre-service, so in students. And there, based on this survey, and on other tools, we developed a curriculum. And later on, we pilot tested this curriculum in a vaccine training. So if I can have the next slide. So I would start with the assessment that we did in healthcare providers that are in service. Therefore, we created what we called a tool. We created the Vaccine Training Barometer. It's an online survey of approximately 12 questions that was used to assess the needs for training of the healthcare providers, but we also tried to monitor the confidence of the healthcare providers to communicate about vaccines. And with this tool, we also try to collect questions that healthcare providers could not answer when they have talks on vaccines with their patients. So this survey is available in Dutch, English, and Spanish. It's also became available in more languages, but I will come on this topic later when we talk about the sustainability of this vaccine training barometer. We had 2 pilot tests of this barometer. We had it in February 2020 and in January 2021 in Belgium. And we also, to see if this is not only applicable for our setting, we also did it at the University of Barcelona. They did also the vaccine training barometer, and they did it in January 2021. So if I can have the next slide, there we have the results of this pilot testing. We compared the second round of Flanders with the first round in Spain. And what you can see there is that 2 on 3 healthcare providers doesn't feel confident at all to answer questions about vaccines. So it's clear that people are not confident to talk, healthcare providers are not confident to talk about vaccine. And in Belgium even, they mentioned that they didn't gain enough knowledge out of their standard education. This is different with the Spanish part, where you see that half of the people think that they get sufficient knowledge by their standard education. What is very convincing is that more than 90% of the healthcare providers we surveyed, they are willing to follow extra courses. And then out of this survey, we also learned that 50% got questions in the last 3 months that they could not answer. So they get questions where they don't have an answer on. If we compare the first round with the second round, the first round was done before the COVID, and the second round was in Flanders was done in middle of the COVID pandemic. We see that there is an increase of more than 20% of healthcare providers who get questions they could not answer. So it means that they didn't have the tools to answer questions, and we think that these were questions mostly on COVID. It seems that we can call this tool a barometer because we can monitoring the amount of questions that are coming up that healthcare providers could not answer. If I can have the next slide. That's what I already mentioned, is that this barometer can be used for monitoring the questions that are coming up, but also to monitor the confidence in the vaccines. Therefore, this barometer was also used in the Union project, the Coalition for Vaccination. They used our barometer to survey the confidence in their members. And that's the reason why we have also now much more languages available. So the survey is applicable in more languages. If I can have the next slide. How we see the use of this vaccine training barometer in the future is that we would like to use this vaccine training barometer prior when we are developing a vaccinology course to really assess the need, but also to assess the need on the certain topics that they want to have in a tailor-made vaccinology training. And this vaccine training barometer could also be used to collect questions healthcare provider could not answer. And we see this as an input for a frequently asked module or a fact check model that can be created to serve as an information tool for healthcare providers. So we think that this vaccine training barometer could really a sustainable tool that can be implemented in the different countries. If we can have the next slide. So besides the healthcare providers in service, we also assess the need of students to have more information on vaccines. So we, thanks to the coalition members or the student organizations that are part of the Coalition for Vaccination, they distributed our survey for students, and we got more than 3,500 responses, and we could conclude out of this assessment that 1 in 3 students doesn't feel confident to reply on questions about vaccines. Half of the medicine and nurses and pharmacy students indicated that an extended module on vaccination in their curriculum was really needed. So they need more information in their current training. If I can have the next slide. So if we base ourselves on the outcome of the healthcare provider survey, so the barometer and the students, there on this, we created together with what we were learning on a list of training on vaccinology that already exists. We used all this information and we collected all of this and we created an optimal or a curriculum that can be used for students as well as for healthcare providers. If I can have the next slide. So this module, the training curriculum for in-service and pre-service training contains 8 different modules. It goes from the immunology, from the history of immunization until the practical skills. Everything is very well described in a part of minimum content and a maximum content. And we, for each module, we specify very clearly the learning outcomes. So at the end, we had a complete curriculum that is available on our website and that will also be available on the EU-JAV websites when the report is approved. Can I have the next slide? So once we had this curriculum, we wanted to pilot test it in the 2 settings, so in the healthcare providers in service and in the students part. But due to the COVID pandemic, it was very difficult to organize a meeting where we brought together the healthcare providers and the students. So what we did is we did a pilot testing in our summer school on vaccinology that we organized last August. And there we took into consideration the curricula. We based ourselves on the curriculum to create the training for the students, and an app was created, and each session could be evaluated by the students. So based on this evaluation, we optimized the curriculum after we did this pilot testing. But we thought that it would be also good that we had some input from the healthcare providers themselves and not only the students on the curriculum. And therefore, we did a review round of the curriculum in the Coalition for Vaccination. So we asked all members of the Coalition for Vaccinations and the Scientific Advisory Board of the Immune Project to review this proposed curriculum. And we took into consideration all updates and we adapted the curriculum so that we can say now that we have an optimized curriculum that we see as a tool for, or as a quality tool to see if you have a training, you can check if all parts of the curriculum are mentioned in your training, or you can start with this curriculum to build a new training if you want to have an optimized training. So if I can have the next slide. So what we think out of our work that we did in the EU-JAV, what are the sustainable outcomes, because we were part of work package 4, where we want to create a sustainable outcome. We have 3 major things created that can be used in all countries. So first of all, we have a curriculum on vaccine and vaccination that can be found on the website of the EU-JAV, and that can be used as a tool to create new trainings or to optimize your existing training. We have the vaccine training barometer, who is really a sustainable tool. We would propose to, before starting to create a tailor-made training, to first run the vaccine training barometer in your healthcare providers so that you can adapt your training based on the needs of the people that need to be trained. And we already started to use this item, so the barometer and the curriculum, we use it now already in the new project in Union, where we develop, based on the curriculum, a train the trainers model that will be given in June 2022. And also the vaccine training barometer was used to assess the need for training in the coalition members. And this was done last December. So we already used the training barometer. So in conclusion, we can say that we have developed in the EU-JAV a major sustainable outcome that can be used to optimize the healthcare providers' training as well as the students' training. And we really would appreciate if this can be used in next projects.
Thank you, great. And of course, you stay with us for the discussion. We'll move on to the second presentation now with Ginevra Papi from the ECL. Dear Ginevra, are you with us?
I surely am.
Yeah, well, so welcome and good afternoon. So the floor is yours, Ginevra.
Thanks a lot, Majid. And actually, I believe I'm the last presenter of the day. So I want to thank the audience for sticking out with us, both online and in Paris. And also, I join Greet in thanking the EU-JAV coordinator and our work package leader, Majid, and the team at the Ministry of Health and Solidarity in France for the kind invitation. So my name is Ginevra Papi, and I am the communications officer at the Association of European Cancer Leagues, based in Brussels. And I'm delighted to be here today to present, hopefully quite shortly, the work that we did towards developing an effective strategy to raise awareness about vaccination among a cross-section of European young people. The strategy was actually co-designed and implemented with a very valuable input of our youth group. And you can see some of them here on the left-hand side of the slide. We call them the so-called youth ambassadors for the European Code Against Cancer. And essentially, this is a network of about 50 students and young professionals aged anything between 18 and 35 years old. They come from different countries and backgrounds, and they're based across the WHO European region. And they all have an interest in health promotion with a focus on cancer prevention. And essentially what they do is really to promote and disseminate at the local level the messages of the European Code Against Cancer, which is a health literacy tool that hopefully some of you are aware of. And the European Code Against Cancer actually includes a specific message on the importance of vaccination, especially vaccination for hepatitis B and HPV. So as I mentioned, the strategy was that we co-designed entailed the implementation and also the evaluation of 2 pilot Europe-wide competitions. The first one in 2019 aimed at school-aged children between 7 and 18 years old. And the second one focused on young people up to 25 years old. So let's have a look at the 2019 competition a bit more in detail. So it took place in March, around March, April 2019. What we did was really we reached out with the help of our youth ambassadors to schools principals in various schools, primary and secondary, across the WHO European region. And what we wanted is that they would help us kind of engaging students and asking them to work in groups of 3 to create public service announcements, in particular posters and short videos about the importance of the hepatitis B and the human papillomavirus vaccines, as well as their uptake. And these public service announcements that they created were meant to raise awareness among their own peers. So what we asked was that the teachers would kind of introduce the topic in perhaps a session or a module, and that the messages included in such service announcements would be in line with the info provided, the official information provided within the European Code Against Cancer, which was developed by the International Agency for Research on Cancer and by the WHO. So you can see a bit on the right-hand side, when it's too small, a bit how many countries participated and kind of the age group. But in short, we received about 40 submissions from 10 countries across the WHO region. And what we did with we shortlisted the posters and video and disseminated them widely on social media during the European Immunization Week. So this is one of the official awareness observances that's coordinated by the WHO Europe office. So what we did is we put them all on social media, in particular on Facebook and Twitter, and we asked people to vote on their favorite entries. So the submission that received the highest number of likes across all platforms were declared the winners on the last day of the European Immunization Week. Next slide, please. Now, briefly, I wanted to also give an overview of the 2021 competition, because actually it was slightly different in format. As you can imagine, back in 2019, it was still pre-pandemic times, so it was actually feasible to reach out to schools. But in 2021, we had to adapt the format. So differently from the first edition, the target group this time was not actually school-age children, but it was more like teenagers and university students. And we didn't ask them to work in groups or work in a school-based setting, but they could work on their own submissions and the spare time, and they did not need to be affiliated with any schools or universities. The competition, once again, was around March, April, to mark the European Immunization Week, because we found during the first edition that it kind of helped boost the message a bit more to capitalize on such an occasion. And the special focus this time was on the HPV vaccination, because we also wanted to raise awareness of the global strategy to eliminate cervical cancer as a public health program that had been published by the WHO. This time also a novelty was that we had two different categories. And the first one was the creativity competition, which kind of welcomed different types of simple and complex graphics. Again, posters, but mostly digital, but also the type of thing that young people like more, for instance, memes and GIFs, stickers. And we also accepted short videos for that category. We also wanted to add a slightly more complex category for university students. So this time we also introduced a case study competition. So we asked participants to design potential interventions to promote the uptake of HPV vaccination in their local context based on their own research. This time, again, we did provide participants with a list of facts about HPV and cervical cancer, so that they could also learn evidence-based facts in the process. And also we give them a list of free design softwares and websites that they could use to create their own designs and graphics. So there was also this didactical aspects in comparison to the previous edition. In one last thing I wanted to mention that was different from the previous edition was that we wanted the competition to kind of continue with some sort of follow-up activities. So we didn't want to just have something in March and April that ended like that. So we did an extra effort to ensure that there was some sort of follow-up, especially from our youth ambassadors. So as after the competition, our youth ambassadors organized a live session on Instagram with the WHO cancer ambassadors to discuss the topic of vaccination more in general, as per the EU-JAV, as well as delve deeper into into vaccination for cancer prevention. And then also our youth ambassadors based in Bosnia, Croatia, and Serbia actually created a video with VIPs and influential personalities from their own region. Some of them were cancer survivors themselves or just influential personalities to raise awareness of the vaccine in their own region. And they also organized a webinar with experts and scientists aimed at young people to discuss the topic further. Next slide, please. Okay, so I'm coming to the conclusion of my presentations. So basically, what was the value of implementing our 2 pilot action, communication action focusing on young children, and what should we kind of take stock of for the future and to make this more sustainable in the future? So some of the main considerations I've added here in the slide. I'm not going to read them out, but I'm just gonna point out a few of them. And I think most importantly, what's important from our pilot communications is that they can now provide some sort of benchmark to assess future competitions. But to look a little bit more in detail on the lessons learned, I think basically free online competitions, we found that free online competitions are a fun and engaging way of raising awareness of vaccination, and as well as raising awareness of, let's say, the project / the brand, in this case, the EU-JAV. And also it's a fast and cost-effective way of build a follower base of followers that usually you wouldn't get from organic content. We also found that it was really useful to capitalize on specific awareness days and months, especially the European Immunization Week. And there's also an awareness day specific to HPV. So our communication efforts really were amplified through these kind of observances, and both at the national and international level. And the final point, maybe from the lessons learned, that I want to raise here is that we found that peer-to-peer communication was very essential. So our youth ambassadors were instrumental in helping us reaching out to schools, because they're not one of our target groups at the Association of European Cancer Leagues. So we mainly communicate and represent cancer associations. Some of them do work with young people and with schools, but it's not a direct target issue. So it was very important for us that peer-to-peer communication happened, and that young people got to know about the competition from their own peers. 2 final points that I wanted to raise were more on the negative side of things. Lessons learned were that it was quite difficult, and probably this point links to the previous session on vaccine hesitancy. It was quite difficult to getting primary and secondary schools involved in our competition, even before the first wave of the COVID-19 pandemic, because as mentioned before, this is an increasingly sensitive topic. So teachers were actually not very willing to introduce the competition to their own students and or include a specific lessons on vaccination, aside from the one that's meant in their own national curricula. And the teachers were not really willing to ask permission to the parents to get their students involved in extra activities. So there was a bit of a caveat, and that's why in 2021 we changed the format a little. And another thing is that, of course, organizing Europe-wide competitions required much more time and resources than what we planned for. So probably small NGOs like ECL are not best placed to lead on the implementation and evaluation of the competition. Actually, we couldn't really evaluate it in a way that we would have wanted. We didn't have resources to do proper implementation research on the ground to assess what was the impact of the competition in terms of knowledge of vaccination and behavior change. So we think that if the Ministry of Health or their contractors at the national level were to take on this project, it would be probably easier for something like this to be run by a big organization. And I think I'm just gonna end here, and thanks a lot for listening.
Thank you very much, Ginevra. Thank you very much, Ginevra. So we are going now to move on the discussion session. So we have with us 3 panelists. I'm very happy to welcome them. They are all online. So first we welcome Mr. Marcus Kujawa from the Standing Committee for European Doctors. Good morning, good afternoon, Marcus.
Good afternoon, and thank you very much for the invitation and all the very interesting presentations. So I'm from the Standing Committee of European Doctors, CPME, and we are representing the national medical associations across Europe.
Excuse me, Marcus, I would just want to present the 2 other panelists before we start the discussion.
Sure.
I will also welcome Georgia Orfeanu from the Cyprus Association of Cancer Patients and Friends.
Good afternoon,
Georgia.
Good afternoon, everyone. Thank you. It's a great honor.
And we welcome also Bolette Sobor from the Danish Health Authority. And Bolette is also sitting in the Member State Committee of the EU-JAV. So good afternoon, Bolette.
Good afternoon.
Okay, thank you for three of you to be there. So I will start maybe with you, Marcus. As your institution, as you mentioned, it is co-chairing the Coalition for Vaccination. I would like to know how the work performed by Grit and his colleague on healthcare professional training is important and relevant for your coalition and for you. And do you have a view for continue and sustain this work inside the coalition, for example?
Thank you for the question. So indeed, yes, CPME is co-chairing this coalition for vaccination, which has been mentioned now today for a number of times. We do it together with the European Associations of Nurses, they are called EFN, and the community pharmacists, they are called PGEU. And it was already mentioned in the morning, I think, that the coalition, it was originally convened by the European Commission in 2019. Nowadays, at the moment, it brings together almost 20 European associations of healthcare professionals, different healthcare professionals, not only doctors, nurses, and pharmacists, but we have also midwives and dentists and physiotherapists as our member in this group. And yes, so the coalition is currently supported by an EU-funded project called Immunion. This was also mentioned by actually our project coordinator, who was one of the panelists in the morning session, and now by Greet also in her presentation, as the University of Antwerp is also partner of the Immunion project. So if I think what is relevant and useful for CPME, but also for this coalition for vaccination, I can go maybe back to the first part of the Greet's presentation, because last summer, related to this Immunion project, we conducted a survey with a similar objective to find out healthcare professionals' views on their vaccination training needs. And here, as Greet already mentioned, we actually used the vaccine training barometer developed in the EU joint action as a basis for our own survey. So we tailored the questionnaire and the questions to be suitable for our needs and the purpose of the Immunion project. And I can say that the results of this survey, they were very similar compared to the assessment made in the EU-JAV. We received over 3,000 responses from, I think, from all the EU countries and from outside EU as well. And also for us, the main finding was that there is clearly a need for additional vaccination training for many healthcare professionals in Europe, and that the majority of them are willing to follow extra courses. Then what comes to the part 3 of your work on developing standardized training curriculum and guidelines, I think all the 8 modules looked very relevant. In our Immunion survey, we asked healthcare professionals what are the most frequent topics of the questions that they receive, and they seem to center around vaccine safety and side effects, but also around effectiveness and the working mechanisms of vaccines, and also vaccination schedules, national and regional. And we saw that the 3rd module you showed earlier today, it addressed vaccine safety and vaccine development. And the 5th module was about immunization policies and schedules. So particularly, I would say that these 2 would be very relevant when it comes to the training needs of healthcare professionals. Another thing I find relevant and useful is the module 7 that you showed on understanding active listening and communication about vaccines. This topic has been discussed lately, I would say quite a lot, that how could healthcare professionals communicate better about vaccines and vaccination. And we have seen that there are European countries where vaccination is not really addressed enough in the curricula. And I would say that this communication aspect even less. And therefore, actually, as part of this Immunion project, the University of Antwerp is coming to CPME's next General Assembly in 2 weeks to organize this kind of special session on communication around vaccination. And I have to say that we are pretty excited about this and looking forward to seeing how it goes and to see what is our members' feedback on it. And quickly to the second question, how all this work can be continued and sustained. I feel that often this kind of EU projects and joint action, maybe they are somehow forgotten after the final payments are made, because there's no simply people who are assigned to take care of the follow-up actions. But fortunately today we already heard that you have some plans how this work can be continued and how these results would be disseminated at first. Because I think the first step is really to let people know about the results of this joint action. And I think we have discovered sometimes that the information of different joint actions and European projects, they don't really reach the people at the national level. And this is why we have actually invited now Work Package 8 of EU-JAV to tell more about the results to our this upcoming General Assembly that I already mentioned. And I think that will be very interesting for our members to really hear from you directly. And we are looking forward to that. Maybe I stop here and
thank you,
give the floor to the next one.
And thank you for your very important and useful comment. Maybe Grit, you want to add something?
No, I only want to mention what Marcus already said. So we are working in union where we take all what we learned and what we created in the joint action. We take it with us and really develop tailor-made actions based on what we did in the EU-JAV. And this tailor-made is one part. We are creating a train the trainers module based on the curricula, but we also are doing in the CPMA, for instance, a meeting. We are doing a side session from where we are focusing on the communication, and this is really on the module of communication of the curricula. We took it and we created there really a session, and we asked people like Eddie Larsson, but also Stefan Lewandowski to come and to talk about communication, how to communicate, very concrete for the GPs, how to communicate about vaccines. That's in fact what we are doing now based on what we learned out of the work in the EU-JAV. So we really created, I think, something very sustainable, and we want to push it through other European projects. That's our next step, in fact.
Thank you very much, Grit, and it's very concrete also. We see the concrete consequences of your work. So thank you very much, Grit. So now I will turn to Miss Georgia Orfanou. Georgia, as a representative of Patient Association, I would like to have your view on the type of communication that ECL has launched during this joint action toward young people. And in particular, do you think that this kind of school competition can be replicated by your association or other association of this kind? So please, Georgia, if you can comment on this.
Of course, thank you. Thank you very much. Dear Jean and Grit, congratulations and thank you, because both of the projects are commendable, they're important, and they could be useful to me and to my colleagues at PASIGAV, especially for those of us in the social marketing department, as we work on cancer prevention programs, and HPV elimination is one of them. We strive to create awareness about cancer and to make a positive impact on social behavior as regards cancer prevention and early detection, and as regards wellness and quality of life. And now as a marketer, I want to be curious and I want to learn and to be inspired and to add value to what I do. So for starts, I have to say that I love the slogan, be wise, immunize. It rhymes, it's creative, it's motivational, and it also serves as an inspiring reminder about the power of wisdom and knowledge, which, if I may add, wisdom and knowledge are greater than any war weapon. And if I may, I need to say that it is extremely sad nowadays to watch the loss of life and the distraction brought up by the war. And may the leaders of all the countries involved to be given the wisdom and the peace at heart so that the loss of life is prevented and the distraction of the civilization is averted. May God bring peace to Ukraine, Russia, and the whole world. For the greatest prayer of humankind asks not for victory, but for peace. Now, being in the field of social marketing and specifically in cancer prevention and control, I would also copy Kofi Annan and repeat his words that it is our duty to make peace with cancer. And according to the European Center for Disease Prevention and Control, the ECDC, the EU's annual incidence rate of human papillomavirus is 33,000, with a mortality rate of 15,000. The good news is that there is primary prevention about it, as we know, being the vaccination, which is one of the most efficient ways to prevent the virus. Nonetheless, full coverage remains extremely low, with a universal coverage falling well below 90%. And this applies to Europe, and it also applies to Cyprus as a result of the COVID-19 pandemic. So communication that leads to engagement is crucial. And I'm really pleased to hear that the Be Wise Immunize competitions have successfully met the KPIs despite the difficulties you had, the KPIs that were set, and had the traits of a successful social marketing campaign, such as a well-defined target audience. The goals were clearly defined, the message was highly targeted and consistent, and the use of integrated marketing communications was highly beneficial, as I've noticed, because it helped to build the brand's image. It created an experience for the audience. It reached out to new audiences as well. And it probably generated cost savings too, right? Now, in addition, I've seen that the communication strategy was clear, concise, concrete, correct, and coherent. So this adds to the adaptability of the project. And in other words, it enables the project to be easily adapted and replicated by other associations interested in doing so. And well, as far as PASIGAF is concerned, and as I've already mentioned, one of our major projects since 2010 is the elimination of HPV and its related cancers. And we are really proud that a part of this project was the first winner of the NGO category of the 2020 EU Health Awards, titled Promoting Vaccination in Children. Hence, the project Be Wise Immunize could contribute to our program as a tool to enrich our communication with teenagers and to help us engage with them effectively. These are my comments. Thank you.
Thank you very much, Georgia, for this comment and the role you had for this complex situation we live actually. Okay, thank you very much. I will maybe ask Ginevra if she has an additional comment.
Thank you. Just very briefly, I wanted to thank Georgia both for making the time to be here today. PASIGAF is one of our valued members of ECL, and also I appreciate the kind words coming from an experienced social media marketers. As mentioned before, ECL is quite a small organization. We are a small secretariat of 4 people, and I lead most of our internal and external communications. And I'm pleased to have Georgia's expert opinion on how the campaign went. Just to add maybe a few figures. As I mentioned, this was a pilot and it was the first time that we had an action of this sort. So I think really the value is also in, now we have some figures that can be used as benchmark to assess future competitions. But I think, our small effort, we still managed to have over 5,000 people, unique views on our web pages connected to the EU-JAV, and we managed to reach over 10,000 people on social media across both competitions. And also engagement from young people was quite high in terms of comments and likes. So I'm hoping that, as Georgia mentioned, this could give some ideas to people who would like to try out similar efforts in their countries, and really to have a baseline to assess further. So thanks for that.
Thank you. Thank you.
Thank you, Ginevra. Thank you, Georgia. So I will now turn to our last panelist, Dr. Bolette Soborg. So Bolette, I would like to have your perspective on both presentation. First on the healthcare professional training, and after regarding the communication campaign. And as we know, in Denmark, you have a big communication campaign about HPV vaccination several years ago. So I would like to have your member state perspective, if I can say that. So Bolette, please.
Yes, thank you. And thank you for the invitation for the meeting today. First, my comment on the communication and training part. It was a pleasure to read and to follow the presentation, Greet. And we have done very similar work at the member state level, and our findings was about the same. That actually there is a need for further training, and then also that, a bit to our surprise, it's also on the fundamental level of the use of vaccines, whereas we had more focus on the communication part, that how to communicate about the difficulties of vaccine hesitancy or such likes. But actually there was also very much used for the rest, as in you presented in your curriculum. So I definitely think that we can use it, and we will probably adapt it to our context in Denmark. But given that I'm sure that had you made the pilot in Denmark, it would have looked much the same. I'm sure that this would be useful. I mean, one of the questions was, how can you implement it in your policies? I think that's maybe taking it a step too wide. I don't think we will implement it in our policies, but I definitely think that we would use it as a offset for making material for the Danish GPs and nurses and all the other staff that do the vaccination. So thank you. And on your the pilot on the youth and the children, I think it was very fresh and very interesting to see. I think, was it, you can answer afterwards, Genevieve, whether this was all organic reach, because we've made a very big communication campaign in Denmark on the HPV side. And actually it does take a while to build up a follow base, but actually when you do, they are quite, of course they need material to interact with. But if you do that, actually we have, together with our cancer society, our Danish Cancer Society, actually kept that going on Facebook for years. So we just we're closing it down now after, I think, 4 years in the following the immunization week coming up. So, but that has been a tremendous success. We've never done anything like you mentioned with contests among children, and I think it's a very interesting idea and to be able to engage, because we've made more of our content is made for the parents who do the decision of the HPV vaccine, not for the children themselves. So maybe we should dig into that and try to make more of a be in eyesight with the children and look into whether this would be useful in the future. We are not able in Denmark to use, as you do, you have prizes and stuff, and I think that would not be ethical, acceptable. So I think coming from us, so I think we have to abstain from that. But thank you.
Yeah, of course, we have to adapt according to the social cultural context. It's true. Do we have any additional comment from our panelists or from our speaker, Ginevra or Grit? It seems not.
If I can make a final or a comment final for it's what our dream in the far future is that we can take the curriculum and that we on each item can link trainings that can be as a toolkit for all trainings developed for healthcare providers. That would be the ideal situation, so that when a healthcare provider has a question or want to have a training, that it goes to a certain website and find the links to this curriculum. So if this is the dream that we have in the future for this outcome on training, because we also want to avoid that you have a bunch of training for healthcare providers so that they have to follow hours and hours on training. This is not the idea that we have in mind. It would be a very dedicated training, and that they can come and pick the part that they needed and that they want to follow. So that's what we want to have in the future if we have extra funding to create this kind of trainings. But it's a dream.
No, it's not a dream. you will succeed. Thank you very much, our Ginevra, Grit, and our panelists.
Sorry, if I may add last comment, just to thank Bolette also for her kind words and for finding this our presentation, our competition like fresh. And maybe if I can add a few words about how we use social media to promote the competition. So in the first case, as it was addressed as school-age children, we decided to do this, let's say, public voting step. We thought that it would be mostly the parents being on social media, because I mean, actually these days children are also social media everywhere, but at the time we thought there will be mostly the parents kind of doing the voting. So we did so mostly on Facebook and Twitter, and it was all organic content. And I think it was because of the public voting that our follower base grew, and also that we kind of had quite a lot of traffic directed to the EU-JAV website, as well as our own, including the European Code Against Cancer page. And then in the second instance, we did make use of paid boosted posts, so-called boosted posts on Instagram, as the audience was towards teenagers and university students, and that helped a lot. So, but I must say that I use boosted posts in my job quite a lot, and there's always kind of mixed results. So it very much depends, and maybe also Georgia agrees with me, it very much depends. But for the 2021 competition, also because it was, I guess, still pandemic times, people were quite a lot spending time at home. So it was easier for them to just scroll through their walls. And that's how we did it. And in terms of prizes, it was a bit, the issue was that, of course, we had to find something that will be supporting our public health messages. So it couldn't be money really, because we give it to the children. So in the end, we opted, and also the winners were across the whole WHO region. So it was something that we had to post. So in the end, we decided to, our prize was gift vouchers for sports, for different types of sports stores in their own countries. And that kind of, I think, was in more or less in line with what we were trying to achieve in terms of promoting health supporting public messages. So I wanted to clarify. Thanks.
So, Christine. Okay. We have a... Ah oui, je vais mettre là. An extra topic to present from the VP4 is a sustainability plan. As you know, as JAV and this conference come to a close, it's important to speak about the sustainability of the JAV main output. This is the focus of the presentation that Augustin will do in a few minutes. Sustainability is about integrating the tool and evidence-based practices into national, but also into the EU level. In each joint action, there is a work package dedicated to sustainability. This is a compulsory work package. So we were in charge at the Ministry of Health of this work package for the joint action on vaccination. So Augustin, we will present you the main feature of the plan we have developed and how we try to make the best use of the ambitious health union legislative package. So Augustin, please, the floor is yours.
All right. Thank you, Majid, for the introduction. Okay. All right. Sorry for that little delay. Hopefully it works now. So as a short introduction to the presentation of the sustainability plan, which will look after the end of the EU-JAV, we wanted to take a step back and to look at the context of the EU-JAV as well as the origins of this joint action once again. So as you all know, in 2018, we released both the communication from the Commission and the Council recommendations on vaccine preventable diseases, as well as a year later, a roadmap, which included the JAV as a key project. Of course, the COVID-19 pandemic has collided with the EU-JAV, but this crisis has, in turn, also allowed the implementation of key European projects, especially regarding joint procurement of vaccine and information sharing. And the COVID-19 pandemic has also created a dynamic for the evolution of the European Union towards a health union that we are going to talk about just after. But first, about the more technical aspect of the elaboration of the sustainability plan. So the elaboration of the sustainability plan stems from the first objective of the EU-JAV, and in particular, as it looks to ensure the sustainability of the outputs of the EU-JAV, it follows a double objective to both ensure their sustainability, their integration at national level into national policies, and their support at EU level within relevant structures. The elaboration of the sustainability plan has been achieved through a close cooperation with member states. And to allow for this cooperation, a vaccine network has been set up in 2019. And as a key part of the EU-JAV governance structure, it comprises both a member states committee and a stakeholders forum, and was tasked with providing strategic guidance, support, and feedback for the elaboration of the sustainability plan. This slide in particular aims at showing you the stepwise approach that we took in elaborating the plan. And by the end of the joint action, the Member States Committee has been consulted no less than 3 times, including once very recently in January 2022. 2 drafts for the sustainability plan were released respectively in September 2019 and January 2021 to the partners for their feedback. And the final report that we present today takes stock of the comments received from both drafts, as well as it offers a new structure. It also offers perspectives for the integration of JAV outputs and objectives at different time horizons, and connects to the evolution of the European Union towards a health union through a tool that we have developed, that is the review of the health union framework legislative package. And I'm going to talk about it just now. So as we have seen earlier, a key characteristic of the EU-JAV is the alignment of its objectives and outputs with the gaps that have been uncovered by the COVID-19 pandemic. And so analyzing the evolution of the European Union towards a better preparedness, better risk assessment and capacity assessment abilities is paramount to understand the options that are offered to us regarding the integration and sustainability of EU-JAV outputs. The the Health Union legislative package comprises a new mandate for the ECDC, the European Centre for Disease Control, a renewed mandate for the European Medicines Agency, as well as a revised regulation on serious cross-border threats to health, and the creation of the Health Emergency Preparedness and Response Authority that we know as ERA. It was important to us to understand the ways that these evolutions intersect with the EU-JAV outputs in their scopes and objectives, in order to identify the measures that already ensure the sustainability of EU-JAV outputs, as well as spaces for the integration of EU-JAV outputs at EU level within relevant structures. We have analyzed those legal texts in a systematic way in order to map the relevant articles for each of the selected EU-JAV outputs, the results of which have been presented in a table that is a part of the sustainability plan in the annex section. The results from this analysis has given us perspectives for the integration of the outputs of the EU-JAV, a few examples of which will be developed later on. But first, the repartition of the selected outputs in the final plan. For the final sustainability plan, we have adopted a 3 groups structure based on the nature and the objectives of the outputs. So first, we have the tools for capacity building at national and EU levels, which aim at reinforcing the member states' national immunization programs, especially regarding the training of healthcare workers, the prioritization of research questions, and the communication. Then we have the shared platforms to ensure cooperation and cross-border data gathering at EU level, which aim at facilitating and promoting the sharing of innovative tools and best practices regarding the harmonized estimation of vaccine coverage and vaccine confidence. And finally, the EU-JAV has also produced recommendations to improve preparedness on vaccine supplies in development, with a particular focus on the funding of research and the management of vaccine supplies. We will now go over 3 selected examples of EU-JAV outputs and the perspectives for their sustainability, as they have all been presented to you just before me. We will not describe them again. So first is the vaccine training barometer, and here we would first want you to see the structure we have adopted for the plan, with 2 levels of integration, national and EU level, as well as the objectives at short, medium, and long terms. The vaccine training barometer could be disseminated to member states through the Coalition for Vaccination, as we have seen earlier with Grit Hendricks and the panelists, which is a long-term partner of the project, and then use at member state level for each member state to assess their own healthcare workers' needs for training. Regarding the European level, the ECDC has recently launched a project for a competencies-based course in vaccinology for primary healthcare workers, for which it has commissioned a needs assessment, and we think an option could be for them to take this tool in order to build this capacity from within, as well as to evaluate the effectiveness of the trainings and the progress made by healthcare workers through periodic assessment. Here, the short-term objective would be to disseminate and promote the common protocol to ensure the uptake at the country level and to disseminate it through the coalition. Then it would be to perform trend analysis on the barometer's results in different countries and, of course, facing specific situation. And finally, on a longer-term horizon, it would be important to update the barometer as well as to look for more funding to do so and to use its output to develop a more tailored training and communication tools. Then in the category shared platforms to ensure cooperation and cross-border data gathering at EU level, we have chosen to develop the platform and corresponding protocol for harmonized estimation of measles-containing vaccine coverage. The protocol could be used by national institutions for the estimation of their own MMR vaccine coverage, and the dissemination to national institutions could be ensured by the national epidemiological surveillance agencies, possibly with the help of the ECDC. At EU level, an option would be to integrate the protocol within the ECDC's own surveillance standards, and likewise the maintenance of the platform could be entrusted to the European Commission or the ECDC, which would be relevant with this mission to establish digital platforms for interoperable systems, surveillance systems. And we have, as we have seen this morning, the discussions are already on their way with the ECDC for the uptake of key experience from the team in charge of this output. The short-term objective here would be to disseminate and promote the common protocol at member states level. Then it would be to ensure that member states effectively report their data to the platform, which is crucial. And the longer-term objective would be to develop cross-border vaccination campaigns across the EU based on the immunization gaps identified through the use of the platform. Finally, the third example we have decided to develop here is the vaccine confidence platforms. And by that, I mean both the online platform to support public health responses to vaccine hesitancy, as well as the vaccine confidence monitoring platform. Regarding the first one, the technical aspect of its sustainability has already been ensured as it is hosted by the European Health Policy Platform and funded until 2027. However, there is a need to ensure the sustainability of the content of the platform. And to that end, we think an option could be the creation of networks of experts to update the database and to exchange on best practices, possibly through use of webinars. Regarding the vaccine confidence monitoring platforms, there are two options. Either it is managed by a European institution or taken in charge by a member state, of course, given proper EU funding. As such, for both platforms, the immediate step would be to update the content of the platform to support public health responses to vaccine hesitancy through the expert seminars that we talked about. Then it would be to exchange good practices across member states funded under the health program, and to use, of course, the vaccine confidence barometer for real-time detection of the changes in trends of vaccine-related conversations on social media, with a view on focusing on false information. Finally, based on the results of the barometer as well as the lessons learned, it would be to improve and adapt health authorities' communication on vaccine in order to quickly react to the spread of misinformation and to tackle that spread. And we think an option on a longer term horizon would be to integrate social media in the communication channels used by health authorities in EU member states in order to allow them to fight misinformation on that ground as well. Moving on to the conclusions and perspective, first saying that the outputs we have presented today here are only a fraction of the total EU-JAV outputs that have been all included and detailed within the sustainability plan. And so the final report, Integration into National Policies and Sustainability, aims at allowing the continuation and maintenance of EU-JAV outputs after the end of the joint action without creating any new EU structure. It offers perspectives for the integration of EU-JAV outputs within member states' policies, and as well as for the support at EU level by relevant bodies, as well as you have seen, roadmaps for the objectives at short, medium, and long terms. The outputs of the EU-JAV offer significant opportunities for collaboration with evolving EU structure, with a view to fight vaccine-preventable diseases in Europe and to reinforce preparedness to cross-border health threats. And finally, we wanted to stress that the sustainability of the work of the EU-JAV in the coming months relies on the joint involvement of the European partners and the member states. And we are very confident that this involvement will be fueled by the European impetus towards a health union, as well as the enthusiasm of member states regarding the usefulness of JAV outputs expressed during the last member states committee. And we want to take that opportunity to thank the member states committee nominees for their support, as well as the EU-JAV partners for having accompanied us all throughout this process. And thank you for your attention.
Thank you, Augustin. I don't know if there is some comments or some remarks in the room regarding this sustainability plan. If not, we may have some time for questions from the audience, either in the room, but I suppose that in the room everybody asks the question, or outside, online. We have a comment by Barbara Ross reminding us that there was a platform of training regarding vaccination, which name is Strengthening the Education and the Knowledge on Immunization, SECI, and you can reach it online, and it's training of either in service or for students, and it exists so. And there were also a remark by Pierre Van Damme from Belgium, saying that maybe part of the vaccine confidence gap came from the fact that the vaccine schedule, in particular for COVID-19, were not the same among the different member states in Europe, and that this may participate in this lack of or this decrease of confidence at one moment. But I think this is something that has been addressed and questioned during this day around the harmonization of the schedule or harmonization of the NITAG decisions. I'm not sure, Laura, if there is any other questions. Okay.
It has been a long day online, yes, for everybody. We will move to my very short conclusion, if I may have the slides. Thanks. Yes, just to conclude and maybe to open after this day of presentation. So we have been delivering to you today, in physically or online, some surveys, some tools, and we will do also some recommendation. We have shared the results of the survey. We have done feasibility studies. We have been workshop, and these workshops and these feasibility studies have been shared and will be shared again. We have seen those actions toward youth that have been launched, and future action should be launched also. We have seen these different platforms regarding the vaccine coverage, regarding the vaccine confidence, regarding the past action to improve vaccine uptake. And all these platforms are dedicated to be fully accessible to anyone. And we have also presented to you the barometer for the need for training and the curriculum to address this need for training. Soon we will publish and we will disseminate it as much as possible to any policymakers or NGOs our recommendations regarding what we recommend after all the work that have been done. And we want all of this, the survey, the studies, the platforms, the tools, the recommendations, the policy brief, to be fully available to any citizen in Europe and beyond Europe. This month, at the end of this month, will be the end of the formal EU-JAV, the closing of the EU-JAV, but it's also the beginning of the post-JAV period. And we hope that for member states, for NGOs, from other stakeholders, for healthcare professionals, for healthcare student association, for funding agency or funding entities, and again, for any citizen, all the EU-JAV achievements that have been proposed, that have been presented to you, that have been shared with you today, are freely available. And please do it, make it yourself, use it, make it last, please. Again, I would just like to pay homage, to pay a tribute to all the people who have worked so hard on the EU-JAV, those in this room, those outside the room. And again, thank you very much to you all. Now it's the end of the so-called public session, and we will have a more restricted session for our stakeholders.